नमस्ते सर।
ऋतुराज सर नमस्कार।
नमस्कार सर, नमस्कार।
सुनील सर ध्यान दो यार इधर। सुनील भाई। मंजूषा नमस्कार। प्रकाश।
यस सर। हेलो
नमस्ते
सर।
सर।
हेलो सर।
ऋतुराज सर नमस्कार।
नमस्कार सर, नमस्कार।
सुनील सर ध्यान दो यार इधर। सुनील भाई। नमस्कार। प्रकाश।
हेलो सर। यस सर। हेलो
नमस्ते
सर।
सर।
हेलो सर।
ऋतुराज सर नमस्कार।
नमस्कार सर, नमस्कार।
सुनील सर ध्यान दो यार इधर। सुनील भाई। हम लोग नरेश सर के थैंकफुल है। नरेश सर अकोला में इस समय।
हेलो सर।
नरेश सर अकोला में है।
हेलो सतीश सर।
अरे स्मार्ट लग रहे भाई।
ऑडिबल हूँ?
एकदम अच्छे से।
आवाज आ रही है?
एकदम अच्छे से।
सतीश भाई आवाज आ रही है?
एकदम क्लियर।
ओके।
अरे
हाय नरेश।
नरेश चार्जिंग करूंगे।
काय सर?
चार्जिंग नसेल तर चार्जिंग करूंगे।
चार्जर नाही आहे, चार्जर नाही आणलं सर.
व्हिडिओ ऑफ करून दे. व्हिडिओ ऑफ करून दे तुझं.
हा.
प्रकाश पांढरीकर सरांना फोन करून दे. पांढरीकर सर
करतो सर.
विनायक पाटील
करतो
सर.
सर.
विनायक पाटील सर करून घे.
चार्जर नाही आहे, चार्जर नाही आणलं.
व्हिडिओ ऑफ करून दे. व्हिडिओ ऑफ करून दे. शिपा सर वेलकम.
लावतो सर, लावतो.
पांढरीकर सर
करतो सर.
विनायक पाटील सर. विनायक पाटील सर करून घे.
चार्जर नाही आहे, चार्जर नाही आणलं.
व्हिडिओ ऑफ करून दे. व्हिडिओ ऑफ करून दे. शिपा सर वेलकम.
हेलो सतीश सर, वीडियो ऑफ करायचा का?
आप कर सकते हैं अभी.
कर सकते हैं ना?
सेक्रेटरी साहब नमस्कार. सुशील राजपूत.
सर गुड आफ्टरनून. सतीश सर.
अरे आले सर आले. प्रभू पाहुणे आले
सर.
आणि पांढरीकर सरांचं
गुड
कौतुक.
आफ्टरनून सर.
खूप छान सेशन घेतलंय त्यांनी आता महाआयपी प्लॅटफॉर्मवर. पूर्ण एक तास होते. विनायक पाटील सर नमस्कार.
वीडियो स्टॉप कर दिया है।
मग रमाकांत पाटील सर जॉईन होत आहेत, मग आपण सुरू करून देऊ. जयंत सर ठीक आहे? जयंत सर ते एका मिनिटात जॉईन होऊन जात आहेत. ऋतुराज ऋतुराज
हॅलो
हा ऋतुराज तयार आहे?
सर, ऐकू येतंय ना?
हो एकदम छान. व्हिडिओ एकदम छान आहे, ऑडिओ छान आहे.
चल.
सर मी किती वाजता चालू करायचं? 1 वाजता का?
नाही नाही, सुरू करतायत ना. आता पहिले एक फॉर्मल इनॉग्रेशन आहे आणि नंतर सुरू करतोय आपण.
आमचं महापेडिकॉनचं हे होतं, सक्सेस पार्टी होती काल. ते आम्ही कर्जतला गेलो होतो सगळे, तिकडनं येतोय आता रस्त्यात.
हे आपल्यासोबत विनायक पाटील सर आहेत, महाराष्ट्र आयपीचे व्हाईस प्रेसिडेंट.
हॅलो विनायक.
हो सर, हॅलो संदीप.
कसं
गुड आफ्टरनून
झालं?
अगरवाल
कसं
सर,
झालं
भंडारीकर
celebration?
सर, संदीप. बस चांगलं तिकडनं येतोय आता, जस्ट एक 5 मिनिटं.
अच्छा, ओके ओके.
संदीप आला तर.
हॅलो सर.
हा गुड इव्हनिंग संदीप.
सर, आज तुम्ही पूर्ण स्क्रीन मध्ये छान दिसून राहिले तर आणखीन छान वाटलं.
शिकायला पाहिजे सगळं. जयंत सर सुरू करायचं?
हो सर, प्लीज सुरू करूयात.
ऋतुराज जयंत सर.
सर, सतीश सर,
हो सर.
ती क्रिटिकॉन तिकडे डिलेट चालून राहिली थोडीशी,
हा
त्यामुळे एखाद्या वेळेस आपल्या पॅनलिस्टचं काही गडबड होऊ शकते.
ठीक आहे ना.
जसं होईल तसं.
मग आपल्यापैकी कोणी होऊन जाईल, तू टेन्शन घेऊ नको.
हा ठीक आहे ना.
जयंत पाटील सर आहेत आपल्यासोबत.
येस येस.
सेक्रेटरी साहेब.
हॅलो सुशील.
स्लाइड्स कोण सर तुम्हीच लावणार आहात ना? स्लाइड्स
मोबाईल ठेवलं.
ऋतुराज
येस सर.
रमाकांत पाटील सर आहेत, रमाकांत पाटील सर. नरेश सर पहिले, नरेश सर, मग जयंत सर. नरेश नरेश गेलाय. हा सुरू करू ना मग.
नरेश सर नाही आहेत ना?
आता जयंत सर पण सुरू कर.
बरोबर.
आणि मग रमाकांत पाटील सर आहे तर रमाकांत पाटील सर.
ओके ओके.
हा
स्टार्ट.
हो. प्रकाश
येस सर.
हा सुरू करायचं.
हो सर.
तिथे युट्यूब चालू आहे.
येस सर, चालू आहे.
ठीक आहे. ऋतुराज.
Yes, sir. Good afternoon, everyone. Myself, Dr. Ruturaj Deshmukh, Treasurer IIP Amravati. Welcome you all for this CME on very important topic, that is newborn care. We shall begin with short inauguratory function, for which I would like to invite.
येस सर.
हा सुरू करायचं.
हो सर. हो सर.
तिथे युट्यूब चालू आहे.
हो सर, चालू आहे सर, चालू आहे.
ठीक आहे. ऋतुराज.
For which I would like to invite Dr. Naresh Taide sir for inauguratory remark. It seems Naresh Taide sir could not log in. I would like now to invite Dr. Ramakant Patil sir, Executive Board Member, to give his opening remark.
जयंत पांढरीकर सर.
Okay. Now I would like to invite our chief guest, Jayant Pandrikar sir, past president IIP Maharashtra, for give his valuable words.
Dr. Ruturaj. At the outset, a very warm good afternoon to one and all, and warm welcome to all on behalf of Amravati IIP. The convener of today's special CME, none other than our own enthusiastic Dr. Satish Agrawal sir. He is always taking keen interest in organizing all the academic activities, on the extracurricular activities, all the public forums in Amravati, not only in Amravati, outside Amravati also. So I welcome Dr. Satish Agrawal sir, convener. Then our Vice President of the Maharashtra IIP, Dr. Vinayak Patil. Then the Secretary of Amravati IIP, Dr. Sushil Rajput. Newly just joining Dr. Ramakant Patil, who is an executive board member of Central IIP, and all the panelists, all the faculties who are going to deliver their deliberations in these today's one-day webinar. And I am happy that NMC has approved credit points for this. So I wish all the success for this webinar. I know that all the interesting topics have been covered in this today's webinar regarding the newborn, which includes even the ophthalmic side, which includes even the anabolics of the newborns, and all the comprehensive things have been included in today's webinar. And definitely, I'm sure this webinar is going to help all the pediatricians and all the attendees of this webinar. So with these words, once again, I congratulate Dr. Satish Agrawal sir, Dr. Naresh Taide, Dr. Sushil Rajput, and Dr. Ruturaj, and all Amravati IIPs, and I wish a very happy learning to all attendees. Thank you very much.
Thank you, Jain sir, for kind words. Now I would like to invite Dr. Ramakant Patil sir, Executive Board Member, Central IIP, for giving his guidance.
Good noon, everybody, all respected seniors and my colleagues. I would like to congratulate Amravati IIP for such a wonderful newborn care CME. I would like to congratulate all office bearers of Amravati IIP, Dr. Taide, Rajbhoj, and Ruturaj. In addition to that, the staunch, benevolent IIP member of Amravati IIP is a thorough academician, at the same time having excellent network and inclusive attitude, Dr. Satish Agrawal sir. Also Dr. Sandeep Khade, who has got a multifaceted personality. And as Dr. Pandrikar sir has said, that this is nearly comprehensive CME for few hours of newborn care, which will benefit generalist medical officers from PSC and USC also. And it will definitely improve the attitude of generalists for a betterment of a newborn and to come out with the flying colors. I wish all the success for this newborn care CME, and I will again congratulate Amravati IIP for the same. Thank you for giving me opportunity to say a few words with you all. Thank you.
Thank you, Ramakant sir.
Dr. Sir.
Yes. Now I would like to invite Dr. Makarand Vevare, sir, observer from MMC, for giving his inputs. Makarand Vevare, sir.
I think he's not there.
हा ठीक आहे मग सुरू करून देऊ
Okay, okay, sir.
हा
That brings to end of our inaugural ceremony. So without further delay, I would like to start our first session, which will be chaired by Dr. Rajendra Nistarane, sir, who is a senior pediatrician from Amravati, and he is a professor at the PDMC Medical College and director of Life Care Hospital. Our second chairperson is from Alibag. He is Dr. Vinayak Patil. He is a director of Kilville Children Hospital, president of IMA Alibag, plus past joint secretary of Maharashtra IP and past president Raigad District Medical Association. So kindly start the session. Over to you, sir.
Hello.
Yes, sir. Over to you, sir.
Okay. Good afternoon, everyone. I'm Dr. Vinayak Patil. I'm Vice President of Maharashtra IIP at present, and it's my privilege to be in front of you. And I'm thankful to Satish Agarwal sir, Pandrekar sir, for conducting such a wonderful CME on newborn care, which will be helpful to generalists and also pediatricians, plus all the caregivers, which will ultimately reduce the infant mortality or morbidity and mortality in newborns. And regarding the first topic, our first topic is next slide. Hello. Indian Neonatal Action Plan, which was started by Indian government in 2014, with a view to reduce the infant mortality and infant stillbirth rate, and to bring this infant mortality rate to single digit number, and to give this or highlight this, what are the action plans to reduce this mortality rate in India. We have today's speaker, Dr. Manjusha Taide. She is associate professor at PDMMC Amravati, and she has numerous publications to her career. She has completed MD Community Medicine in Manjusha Taide to start her talk. Thank you.
Thank you, sir, for introducing me. Good afternoon, everyone. Respected chairpersons, respected seniors, and my colleagues. At the outset, I would like to thank Team IIP Amravati. Am I audible?
Yes, yes.
So at the outset, I would like to thank Team IIP Amravati, and special thanks to Dr. Agrawal sir for giving me the opportunity to be the part of this CME. Now, with the permission of respected chairpersons, I would like to start my session. So the topic allotted to me is
स्क्रीन शेअर कर पोस्ट कर
स्क्रीन शेअर झाली का सर?
No, madam.
प्रकाश पोस्ट कर पोस्ट
स्क्रीन शेअर सर असा मेसेज येतोय, होस्ट डिसेबल पार्टिसिपंट स्क्रीन शेअरिंग.
त्यांना पोस्ट कर प्रकाश.
Yes, sir.
हा मॅडम, एकदा कराल मॅडम.
हा, ठीक.
स्क्रीन झाली मॅडम शेअर?
स्क्रीन झाली.
प्रेझेंटेशन, हो प्रेझेंटेशन ओपन करा मॅडम.
डेस्कटॉपवर आहे सर, पण
ओपन करून घ्यायचं पहिले, मग ते शेअर करायचं.
बरं.
मिनिमाइज करून घ्या मॅडम, याला मिनिमाइज करून घ्या.
हो.
हा मॅडम. मॅम फुल स्क्रीन. हा मॅडम, हा खाली, हा तेच सेम तेच. राईट. येस मॅम.
Okay, so let us start with our session. So the topic allotted to me is INAP, that is India Newborn Action Plan. So let us start with our session. So the points to be covered under the framework of INAP includes introduction, situational analysis, that is current trends about NMR, the goals of INAP, guiding principles, the 6 important pillars of INAP, monitoring and evaluation framework, and we will have a brief review of some programs focusing on newborns. Coming to introduction, the India Newborn Action Plan is India's committed response to global Every Newborn Action Plan launched in June 2014 at 67th World Health Assembly to advance the global strategy for women's and children's health. India contributes to 1/5 of the global live births and more than a quarter of neonatal deaths. The country has witnessed dramatic reduction in maternal and child mortality rates over the past 2 decades. However, the neonatal mortality rates has reduced much less as compared to the post-neonatal deaths. Even now, 0.76 million newborns die each year, which is highest in the world. Look at this table. Neonatal deaths has reduced from 1.35 million in 1990 to 0.76 million in 2012. That is 44% reduction. Infant deaths has reduced from 2.33 million to 1 million. That is 53% reduction. And under 5 deaths has reduced from 3.32 million to 1.3 million. That is relative reduction from 1990 to 2012 is 59%. So we can see that the neonatal deaths has comparatively less reduced as compared to the infants and under 5 deaths. NMR now constitutes nearly 69% of the total IMR. NMR in the rural areas is more than double that of the urban areas. That is 33 versus 16 per 1,000 live births. Most of the neonatal deaths, that is almost 3/4 of the neonatal deaths that occur within first week of life. And amongst that also, out of that also, most of the deaths that occur within first 24 to 48 hours. The most important causes or the major causes of neonatal deaths in India includes prematurity or preterm, which constitutes 35%, followed by infections, including sepsis, pneumonia, diarrhea, which constitutes 33%, followed by intrapartum related complication, mainly the birth asphyxia, which constitutes 20%, and malformation 9%. This figure shows many of the states, most of the states in India, they have neonatal mortality rates lying between 26 to 30 or more than 30. 4 largest states, that is Madhya Pradesh of India, that is Madhya Pradesh, Uttar Pradesh, Rajasthan, and Bihar. Together, they contribute 56% of India's newborn deaths and 14% of the global newborn deaths. So only state of Kerala that has achieved the single digit neonatal mortality rate. So looking at this alarming situation, the policymakers, they have decided to focus their attention on the newborn health at highest level. And the two important milestones in this direction include the RMNCH plus A strategy and NRHM. So with this background, the INAP was launched with the goals of ending preventable newborn deaths to achieve single digit neonatal mortality rate by 2030, with all the states to individually achieve this target by 2035. And for the first time, the component of stillbirth was also included, stillborn is also included in this program. Otherwise, there are many programs which focuses on newborns, but stillborn component is for the first time included in INAP. So the second objective of this INAP includes in ending the preventable stillbirth rate to achieve the single digit stillbirth rate by 2030, with all the states to individually achieve this target by 2035. The milestones in the child survival programs in India. So Child Survival and Safe Motherhood program was launched for the first time in 1992, followed by RCH, that is Reproductive and Child Health Phase 1 in 1997, Reproductive and Child Health Phase 2 in 2005, National Rural Health Mission in 2005, RMNCH, that is Reproductive, Maternal, Neonatal, Child Health and Adolescent Health Strategy in 2013, National Health Mission in 2013, and India Newborn Action Plan in 2014. Now let us see the 6 important components or 6 important pillars of INAP, covering all the stages of newborn. So these includes preconception and antenatal care, care during the labor and childbirth, immediate newborn care, care of healthy newborn, care of small and sick newborn, and care beyond the survival. So these are the main or important 6 pillars of INAP. Let us see one by one. Preconception and antenatal care. It is well known that the care during the antenatal period and even before the conception improves the neonatal and perinatal outcome. So the important interventions at the family and community level under this head include reproductive health and family planning, including especially addressing the adolescent reproductive health, delaying the age of marriage and first pregnancy, birth spacing. The nutritional related interventions include balanced energy protein supplementation, periconceptional folic acid supplementation, maternal calcium supplementation, multiple micronutrient supplementation, including iron, folic acid, and iodine supplementation, nutrition related counseling and birth preparedness and prevention against malaria. At the subcenter level, antenatal screening for various high-risk pregnancy, including anemia and hypertensive disorders of pregnancy, preeclampsia, eclampsia, antenatal screening for malaria, prevention and management of mild to moderate anemia, maternal tetanus immunization, adolescent-friendly health services, interval IUCD insertion, antenatal screening and management of, again, severe anemia. At the health facility level, the same, again, screening of high-risk pregnancy and their management, including gestational diabetes and syphilis, PIH, anemia, antenatal screening and management of hypothyroidism, hepatitis B, HIV, malaria, adolescent-friendly health clinics as per RKSK guidelines, and postpartum family planning services, including postpartum IUCD insertion and prevention of RH disease using the anti-D immunoglobulin. Second component is care during the labor and childbirth. So the important interventions under this component at family and community level include skilled birth attendance. Even the attending the deliveries by skilled birth attendants, that reduces the newborn deaths by 25%. And following the clean birth practices, simply just washing the hand with soap and water, that reduces the prevalence, reduces the newborn deaths or sepsis, occurrence of sepsis by 15% in case of home delivery, and by 27% in case of deliveries at facilities, and postpartum sepsis or postpartum deaths during the postpartum period by 40%. So the interventions at the subcenter level include identification of complications and timely referral, and ANM are expected to give the antenatal corticosteroid in case of preterm labor, which will reduce the occurrence of newborn deaths by 30%. And ANM are also expected to give the antibiotics for premature rupture of membrane, which will definitely prevent occurrence of sepsis during the postnatal period. At health facility level, the interventions are basic and comprehensive emergency obstetric care, which reduces the intrapartum related deaths as well as complications. Then management of preterm labor, which is again the same, and antenatal corticosteroid in case of preterm labor, and antibiotic for premature rupture of the membrane. Third important component is a immediate newborn care. So immediate care is a right of every newborn. So the interventions at the family and community level include delayed cord clamping, which prevents the occurrence of anemia in the newborn and also prevents the intraventricular hemorrhage. Then interventions to prevent hypothermia include immediate drying and stimulation, ensuring the warmth by head covering and skin to skin care, delayed bathing, early initiation of breastfeeding and continuation of exclusive breastfeeding, hygiene to prevent infection, and at the subcenter level, administration of vitamin K at birth, which will prevent the hemorrhagic disease of newborn. And those babies who do not cry at the birth, neonatal resuscitation is a life-saving intervention. So all the healthcare providers should be trained in neonatal resuscitation. At the health facility level, again, advanced neonatal resuscitation. So these are the interventions at various levels, that is family, community, subcenter level, and health facility level. The fourth important component is a care of sick and care of healthy newborn. So community-based intervention that improves the child survival, it is again well known. So very large number of ASHAs, they are trained in performing the various preventive and promotive health activities like counseling regarding the breastfeeding, regarding the complementary feeding, regarding the immunization, sanitation, etc. And again, the prevention of hypothermia and cord care, identification of danger signs, prompt and appropriate referral, exclusive breastfeeding, clean postnatal practices. So this can be performed by home visits paid by ASHA. And for that, they are paid the incentives of 250 rupees after 6 visits, that is up to the 42 days from birth. And at subcenter level, the interventions include immunization, including the BCG, OPV, and hepatitis B. At health facility, all the intervention except home visits. Care of the small and sick newborn. So again, the interventions at the family and community level includes thermal care and feeding support for home deliveries. At subcenter level, integrated management using IMNCI and use of oral antibiotics, injectable gentamicin by ANM for sepsis, pre-referral, or whether the referral is not possible or refused, then completion of antibiotic course. Then at a health facility level, kangaroo mother care at facility, full supportive care at the block and district level, that is newborn stabilization unit at block level and special newborn care unit at district level, and intensive care services, NICU, at regional level for assisted ventilation, surfactant use, and surgery. Care of the baby beyond the survival. So at the family and community level, the interventions include screening for birth defects, failure to thrive, and developmental delay, follow-up visits for SNCU discharged babies till 1 year of age, and for small and low birth weight babies, the visits are to be paid till, or follow-up is to be done till 2 years of age. At subcenter level, same as community level. And at facility level, health facility level, again the newborn screening for birth defects, failure to thrive, and developmental delays, management of birth defect, including the diagnosis and treatment like surgery, etc. Follow-up of high-risk infant discharge from SNCU and small newborns for developmental delay and appropriate management. So now for proper implementation of this program, so a list of indicators in given and review is taken after every 5 years. For example, for each component, there are 6 important components of INEP, and for each of the component, the list of indicators is given for continuous monitoring of the program. So, for example, for preconception and antenatal care, the indicators include birth to the women aged 15 to 19 years out of total birth, that is the percentage of teenage pregnancy, percentage of pregnant women who received full ANC care, percentage of pregnant women detected and treated with severe anemia. So likewise, the list of indicator is there to monitor each and every component. So this is brief review of INAP. Now there are certain programs under National Health Mission which particularly focuses on newborns. So let us know something about them. So this includes Janani Suraksha Yojana, IMNCI, that is Integrated Management of Neonatal and Childhood Illness at community level, and FIMNCI at health facilities. Navjat Shishu Suraksha Karyakram, Janani Shishu Suraksha Karyakram, facility based newborn care, home based newborn care, and Rashtriya Bal Swasthya Karyakram. Janani Suraksha Yojana. This was launched on 12th of April 2005 with the objective to reduce infant mortality rate and maternal mortality rate by promoting the institutional deliveries. It is modification of National Maternity Benefit Scheme. IMNCI and FIMNCI, that is Integrated Management of Neonatal and Childhood Illness. So this was launched in 2007, and the objective was standard case management of major causes of neonatal and childhood morbidity and mortality. Navjat Shishu Suraksha Karyakram. This was launched on September 2009, and it mainly focuses on prevention of hypothermia, prevention of infection, early initiation of breastfeeding, basic newborn care, and resuscitation. So the objective of this Navjat Shishu Suraksha Karyakram is to train all the healthcare providers in basic newborn care and resuscitation at district hospital, community health center, and primary health center. Janani Shishu Suraksha Karyakram. This was launched on 1st of June 2011, and it is the initiative to provide completely free and cashless services to the pregnant women, including normal deliveries and cesarean operations in all the government hospitals. So completely free and cashless services are provided to the pregnant women as well as sick newborns. The scheme also envisages the free treatment of sick newborn up to 30 days after the birth in government health institution in both rural and urban areas. Facility-based newborn care. So this was launched in 2011, and under this, there is a provision of newborn care corners at all the points of childbirth to provide immediate care to the newborn. Then newborn stabilization units at community health center and first referral units for management of selected conditions and to stabilize the sick newborns before referral to the higher centers. And provision of special newborn care units, SNCUs, at district, sub-district hospital to care for sick newborns, and all type of care is provided except assisted ventilation and major surgeries. Home-based newborn care. This is being implemented since 2011 for reducing the neonatal mortality in rural areas. And the main objectives of this home-based newborn care is provision of essential newborn care to all the newborns, special care of preterm and low birth weight newborns, early detection of illness followed by referral, and support to the family for adoption of healthy practices by ASHA workers. So ASHA workers are the key worker for implementation of this program, because even today 25 to 40% of the deliveries that occur at home. So home-based newborn care, so the activities which are carried out by ASHA workers under this home-based newborn care includes care of every newborn through the series of home visits. So total 6 visits are carried out by ASHA workers from birth till 42 days of life, that is till 6 weeks of life. So examination of during these visits, the examination of every newborn is carried out for prematurity, extra home visits for preterm and low birth weight babies, identification of any illness, follow-up of sick newborns after they have discharged from the facilities, counseling of mothers on the postpartum care and counseling on family planning as well as the breastfeeding. Rashtriya Bal Swasthya Karyakram, this was launched in 2013, and objective is the screening of all the children is carried out to identify the birth defects, diseases, deficiencies, and developmental delays, including the disabilities. And all the children between the age group of 0 to 18 years are targeted under this program. So to sum up about the INAP, so India Newborn Action Plan was launched in June 2014. It aligns with the global Every Newborn Action Plan. The important two goals of INAP includes to achieve the single-digit neonatal mortality rate by 2030 and to achieve the single-digit stillbirth rate by 2030. The important guiding principles of INAP includes equity, gender, quality of care, convergence, accountability, and partnership. The 6 important pillars of intervention of INAP includes preconception and antenatal care, care during the labor and childbirth, immediate newborn care, care of healthy newborn, care of small and sick newborn, and care beyond the newborn survival. And for proper implementation of this program, monitoring and evaluation is done with the help of certain indicators. So thank you. This is all about the INAP. Any questions?
Hello.
Hello.
पाटील सर.
हा येतं ऐकू येतं सर. Thank you, madam, for this comprehensive talk regarding Indian Newborn Action Plan, which has the main goal of reducing the neonatal mortality rate to single-digit number. And as per the 6 pillars of intervention packages, as you have told, are preconceptional and antenatal care, care during labor and childbirth, immediate newborn care, care of a healthy newborn, care of sick and small newborns, and care beyond newborn survival. So these 6 pillars are important in reducing, in achieving this goal of single-digit infant mortality rate. That the take-home message we have. Our next talk is regarding about most common condition we see in newborn, that is neonatal jaundice, and almost we pediatricians see almost daily we must be seeing many patients of neonatal jaundice during our wherever we go for calls to gynecologist. And as we know, 60% of the full-term newborns have jaundice after birth, and 80% of the newborn jaundice after birth. It's a very common condition where
to the hospital.
And to give this talk, Sripad Jagirdar from Amravati, is MD DCH DNB and ex-assistant professor at PDMC Amravati. He was one of the chief organizing secretary of Mahapedicon 2019 Amravati and joint secretary of MahaIP 2019. He's past president of IIP Amravati branch and editor of the book Adolescent Health Hindola Tarunya. So I request Dr. Sripad to start his talk regarding very important topic of neonatal jaundice. Thank you. Sripad, you can start.
Unmute. Sripad, unmute.
Yes. So good. Good evening, everyone. So can I share my slide? Aditi,
Post. You are the post.
okay, am I audible and my slides are visible? Should I start?
Yes, sir.
First slide, neonatal jaundice is visible.
Yes, sir.
Okay, I'm audible also, and I will start with the today's topic. So this is a very common topic and important topic, and I will try to give the justice because while preparing the topic, started feeling nostalgic because most of the things I learned during my college days, and I'm again reading it. So we will try to cover the things and get nostalgic by going through the common topic that we already know in a short. But there are certain few new things that has come, and probably I will like to discuss that topic in details. So let's start with the presentation. Aditi, कसं करायचं पुढे? Aditi, पुढे कसं करायचं? करना बेटा. Okay. फुल स्क्रीन करून दे ना. फुल स्क्रीन. Okay. Back कसं जायचं? Okay, we all know 60% of full-term newborn babies will develop jaundice at some period of time, and 80% of preterm babies will develop hyperbilirubinemia. Probably if the child is less than 32 weeks, probably every child in that category will have got jaundice at some period of time, and this is one of the most commonest cause of readmission after birth. And with the last point is very important that 5 to 10% of the babies with severe neonatal jaundice will require some kind of treatment to decrease the serum bilirubin level so that the acute bilirubin neurological toxicity can be prevented. So number of admissions will be around 5 to 10% of the total babies because most of the preterm babies will have got a jaundice. So remember this, and one has to be very vigilant while examining the newborn babies on day 2, day 3, day 4. So this is all physiology that we all know, and this is very important to understand why the jaundice occurs in newborn child, because there are four mechanisms, different mechanisms. This slide we all know in our undergraduate days. First cause is increased bilirubin production because of the increased breakdown of the RBC. Second cause can be problem can be at the level of uptake at the level of liver. So there are certain metabolic disorders like Gilbert's, and they are associated with the decreased uptake. Then metabolism of bilirubin into the conjugated form occurs in the liver with the help of enzymes UGT1A1, and some problem with that pathology will lead to the causes of jaundice. And third could be a increased enterohepatic circulation, where because of the once by bilirubin products are in the intestine, there is a decreased transient time, decreased slow motility, decreased oral intake. All these will lead to the increased enterohepatic circulation, and that causes again the jaundice. So there are all these known mechanism that is known to cause jaundice in newborn child. So we all know this. So let's move to the jaundice. So many causes of newborn jaundice. Let's elaborate, or let's remember this thing by making a mnemonic with the bilirubin, bilirubin. If you know this thing, then probably we will not miss any of the causes. Like B is for breastfeeding jaundice and breast milk jaundice, though we have to rule all the causes and then we give the diagnosis as breastfeeding jaundice or breastfeeding jaundice. Breastfeeding jaundice is a jaundice that occurs in early age of life, and breast milk jaundice that occurs after 2 weeks or 3 weeks is, we all know the pathology, because the breast milk contains some amount of beta glucuronidases which act on the bilirubin in the intestine and convert them again into unconjugated form, so that it is again reabsorbed in enterohepatic circulation, and serum bilirubin level is more. Then I is for increased enterohepatic circulation. AL is for some liver pathology, either neonatal hepatitis, Allicale syndrome, or various other liver pathologies, which has because of which liver is not able to convert the bilirubin metabolism or conjugate the bilirubin. I is for inborn error of metabolism, like some disorder like galactosemia, tyrosinemia, alpha-1 antitrypsin. R is for Rh incompatibility and other hemolytic disease. U is for unrecognized hemolysis like cephalhematoma, polycythemia, etc. B is for babies of diabetic mother and hypothyroid mother. I is for infections, sepsis, and N is for neonatal cholestasis. So these are the probable various reasons, and one has to remember this while examining the child or while evaluating the child. Then how we approach for the neonatal jaundice. First, most important is visual assessment. Again, this is very important in the examination and assessing the neonatal jaundice, and the sensitivity of patient who has been assessed by visual assessment properly is same as serum bilirubin level. So most of the times. So one has to remember that the patient has to be in completely exposed. There should not be any clothes. There should not be any yellow light also in the room, and there should not be a white background also. One has to do the examination on that, on the basis of that, and we have to find out. The only problem with the visual assessment, if the patient is on phototherapy, probably we cannot assess. And in India, where if we get some very dark skin pigmented child, then probably in that cases visual assessment may not be accurate. But otherwise, most of the time visual assessment is as good as doing a serum bilirubin level. Then if somebody has got a instrument called as transcutaneous bilirubinometer, then it is a very good instrument to assess bilirubinometer. There is no need for finger prick or no need for blood collection, and there are bilirubin monogram available along with the bilirubinometer, and based on that we have to decide whether this child will go for phototherapy or is safe zone or it is in the intermediate zone. So we have to label this child as. Again, there are certain limitations for transcutaneous bilirubinometer. One important problem is if it is not very good for the assessment if the child is less than 24 days, 24 hours old, or if the child is less than 35 weeks old, then probably there cannot be a very good assessment. And if the child we are examining by visual assessment or transcutaneous bilirubinometer, if the value of bilirubin we feel in a phototherapy range, then probably don't rely alone on these parameters. You have to go ahead and do that serum bilirubin by doing a blood test, which is again a very important problem with this visual assessment and transcutaneous bilirubinometer. Again, if the patient is on intensive phototherapy, probably this may not work. Then common investigation we do at the time of admission is mother's blood group, Rh typing, baby's blood group, Rh typing, direct cum test, pack cell volume, PS4 opinion, retic count, mean corpuscular hemoglobin concentration, G6PD level. Though we see hereditary spherocytosis levels patients very less, but if MCSC is more than 36, probably there cannot be any other diagnosis, what most of the experienced people say. So MCSC, by doing just one investigation, we can get a clue whether it is a jaundice is because of hereditary spherocytosis. And then we may need a workup depending upon the clinical situation about septicemia, hypothyroidism, or other metabolic workup. This is case to case basis. Let's see what is a pathological jaundice. We all know what is a physiological jaundice. Most of the patients will have got a physiological jaundice because of some problem in all these four mechanisms. But let's not forget that if ever we get across a patient with any of these, then we have to evaluate in details and do the investigation. Visible jaundice in first 24 hours of life is always considered as a pathological. Then presence of a jaundice at arms and legs on day 2 of life. Again, this is very bad signs, and probably this is very rapid increasing jaundice, and we may need to evaluate such child. Whenever at any age of life, if the palms and soles are also yellow, this is definitely going to be pathological. This has to be considered as a very serious point, and one has to admit the child and do investigation on rapid basis. Then again, rise of serum bilirubin more than 0.2 milligram per deciliter per hour and more than 5 milligram per deciliter per hour in one day is definitely pathological. Total serum bilirubin is more than 95th centile, sorry, it is 95th, it is not 9th, 95th centile on age specific bilirubin monogram. Anytime whatever the bilirubin levels are, but if you get the signs of acute bilirubin encephalopathy like temperature instability, high pitch cry, opisthotonus, retrocolis, maybe all these signs are there, then irrespective of the bilirubin level, this is serious problem. This is cannot be a physiological, it has to be pathological. And jaundice that persists more than 2 weeks in full terms and more than 3 weeks in preterm, they are all pathological jaundice. So we all know Karmer scales. This is modified Karmer scale we have been using, whether the zones has been described as 1, 2, 3, 4, 5, and appropriate bilirubin level is mentioned against that level. Again, remember that whenever there is a 4 or level 5, then don't rely on clinical examination alone. We have to go ahead with blood test. Again, in addition to this Karmer cell, there are certain points that I learned from my seniors. Is always don't rely on the color of the skin, blanch color, the extent of the skin. You have to see the depth of the color also. If it is a very light yellow color, probably the jaundice will fall in the same range of what the scale says. But by after blanching, and if the skin area is very dark yellow or dark orange yellow, then don't rely only on the Karmer scale. This dark yellow color, even it is in the grade 3 zone, probably this child will have got a more bilirubin than what the Karmer scale says. So in that case, just don't rely on the extent of dermal involvement. Also see how the deep the jaundice color of the yellow color is. So that will be more reliable, which is again I learned from my seniors, and I think I should share this information to some younger pediatricians. Again, this is a common chart that we all use, and we all know this is chart that is made by AAP, Indian Academy of Pediatrics, American Academy of Pediatrics, and this chart is very valid for child who is more than 35 weeks. Either they have got some high risk factor and low risk factor, and depending upon this chart, they will tell us if the bilirubin level is in the phototherapy range. It is very difficult to remember all these figures. One has to keep this chart in our NSU and at a handy level in our mobile also, so that one can assess and tell that whether the child is in phototherapy range. Just to remember, I used to remember in that way that at 24, 48 hours, 72 hours, 96 hours, if the patient is in medium zone or medium risk factor, then the bilirubin will be 8, at the end of 24 hours 10, at the end of 48 hours 13, at the end of 72 hours 15, and at the end of 96 hours 18. That is 10, 13, 15, 18. These are the levels. And if it is in the low risk area, then we have to subtract 2. And if it is high risk area, if it is low risk, we have to add 2. And if it is low risk, we have to subtract 2. So, but no need to remember everything. There is a figure available everywhere. But do we have got any charts, or we refer any charts if the patient's age is 32 weeks? Probably this child chart may not help. If the child's age is 26 weeks, and whether we want to know whether this is a phototherapy range or not, probably this may not work. And this has not been mentioned in most of our textbook, Loherty or Nelson, other charts. But we have got a very good guidelines called as NICE guidelines. They have been mentioned here. They are age specific charts and hour specific charts, depending upon and they will give us a guidelines about whether this child will require a phototherapy or will require exchange transfusion. These are called as a NICE guidelines, and probably one should have also have got these charts in addition to these previous phototherapy charts, because this is age specific. They are useful for the child less than 34 or 35 weeks, which is where they are very important. For example, 28 weeks, at the end of 24 hours, even the 5 bilirubin will fall in exchange transfusion, will fall in phototherapy range, and 8.5 will fall in exchange transfusion. So these charts are very important. And we have got very smart intensivists in our institute. Whenever I ask them, is the child's phototherapy bilirubin level is in the phototherapy range or exchange level, they don't go with the books. They have got various apps like Billy Guru and other apps, which by putting the values of bilirubin level and day of life, they will all immediately tell whether it is a phototherapy and exchange. These guidelines were also based on NICE guidelines, but they are available in app forms, Billy Guru apps, which most of our intensivists are using. Then phototherapy, we all know what is the mechanism, that is photooxidation, photoisomerization. We all know the spectrum of light should be 460 to 480. The radiance is 30 micro m per centimeter square per nanometer. All this is the light should be. Then question was in our UG days whether it is a single surface or double surface. Nowadays we don't use these terms commonly. It should be intensified phototherapy. Intensified, whether if we are comfortable with single or double or triple also doesn't make a difference. It should be intensified. Every part of the body should be exposed to this light of spectrums 460 to 470, 490. So nowadays we are more scientific words are using, that is more intensified phototherapy. What should be the distance of phototherapy unit from the baby? In our college days it was said that it should be ideally 30 centimeter to 45 centimeter, but nowadays this is again not used at all. We don't recommend that it should be at least 30 centimeter or 45 centimeter. It should be as close as the baby, because nowadays most of the lights we are using either are CFL or LED lights. They don't cause much problem or much toxicity to the child skin or eyes. So this is not a distance nowadays. We'd say as close to the patient's baby's body. Type of the light, there could be a CFL light, there are LED lights. LED lights are much better than there are blankets and conventional light. Most of the phototherapy most of the NICU centers now are using CFL light or LED lights, where the life is also long, and probably the duration of phototherapy will decrease because of they are a very good source of phototherapy. Then how much should be the interruption time for breastfeeding? Probably 15 to 30 minutes maybe maximum for normal phototherapy. And if the patients will be approaching exchange transfusion, probably we will not interrupt phototherapy while feeding. We will allow only water spoon feeding and continue extensive intensified phototherapy, because that much interruption is also not permitted if the exchange range is in approaching. We know all the vital parameters, urine output, weight of the child, complications, adverse effect of phototherapy has to be monitored, and when to stop is again important. It is not that we have already decided patient should be admitted for 5 days, as I have less number of admission now, and let the phototherapy to continue for 5 days. This is not, we have to stop the phototherapy whenever the phototherapy range for bilirubin level goes below the phototherapy range. We have to stop that, and if possible we have to repeat for bilirubin after 24 hours after stopping the phototherapy, which is most important. So don't hesitate to start and don't hesitate to stop also. Once the phototherapy range bilirubin levels are less than phototherapy range, go and stop the phototherapy. So again, this is an important study that I come across, that is a Cochrane database systemic review analysis published in some 2020. So whether the refractive materials are helpful during intensified phototherapy or not. These refractive materials are like a curtains used around the phototherapy units. Many of these NICU are using these reflective materials, and probably this is a good idea, because what this Cochrane database systemic review says about this reflective materials, that they may decrease the bilirubin level more effectively in first 4 or 8 hours, which is very important, because whenever we are giving intensified phototherapy, that we all know that probably this child may require exchange transfusion if bilirubin is not brought down in next 4 hours. So again, using reflective materials is useful, but only thing is there is a low certainty evidence shows that duration of phototherapy is less. But again, it is a good idea, and only drawback I have felt while using reflective material is probably you cannot assess the baby very easily, because there is covering and you cannot see the baby very easily on that time when the patient's reflective materials are used. But most of the studies say that for first 4 to 8 hours you can use that reflective material, so that the bilirubin is decreased on a rapid basis. Again, what is a exchange transfusion? We all know how to do that and when to do that, which blood is used for phototherapy. So probably I will not go in details for that, but this is a phototherapy charge produced by American Academy of Pediatrician, that tells us about what are the levels at which we should consider for exchange transfusion when the child is more than 35 weeks. And same nice guidelines are used when to find out exchange transfusion are needed or not when the child is less than 35 weeks. This tells that probably if the child has got 48 at the end of 48 hours and it is a high risk zone child, then probably even 14 will be considered as exchange trials. A high risk age group is a lower line and lower risk is upper line. High risk age group is RH incompatibility, AB incompatibility, other hemolytic anemias, patient is having severe sepsis, birth asphyxia. All these will be G6PD deficiency. All these are considered as a high risk. So one has to be, nowadays exchange transfusion requirement are very less because of very effective phototherapy, And also, of course, we say that being after the patient is put on the phototherapy, next level to be done after 3 to 4 hours. By that time, if you have got a very good phototherapy unit, the bilirubin will level will start decreasing, and probably it will be less than in the range of exchange transfusion. So in that case also we don't do, we follow the extensive phototherapy regime only. So now again, let's talk about something new. Let us talk about something fancy which has been available. IVIG we have been discussing after for long time whether it is effective or not. So let's see. Most of the results show that there is a significant reduction in the need of exchange transfusion in the child treated with IVIG. IVIG, the dose is 0.5 gram to 1 gram given 2 hours prior to the exchange transfusion, and probability, but the only thing is that applicability of the result is limited because of low quality of evidence. That is what this Cochrane database systemic review 2018 will say. Though everybody has got a different opinion, but we will see what the Cochrane database systemic review analysis says. So they say that most of the studies shows that there is a significant reduction in the need of exchange transfusion, but there are two studies where blind control, where the results were not known whether IVIG was given or some other placebo was given. So not in that case, these two blind studies were conducted, randomized control, where the results were not known, and what, in which arm the patient belongs to, nobody knows. And there in that study, both the studies, it was found that there is no difference in the need of exchange transfusion and number of exchange transfusion in both the studies, whether the child received placebo or IVIG. There was no difference in need of exchange transfusion or number of exchange transfusions, and there is no significant evidence to conclude that IVIG is useful in, as far as Cochrane databases review analysis says. What the author of this multi-analysis says that the only role of IVIG is in at places where the exchange transfusion facilities cannot be possible on emergency basis, whether they need to transfer the child or no transfer can be possible. At that places, there can be some role of IVIG. Even our textbook Cloherty doesn't say that it should not be used as a routine. Then again, the role of IV albumin, we all know that it has been trial or suggested that 20% of 1 gram of 20% of IV albumin 1 gram per kg, if it is given 1 gram 1 hour prior, then probably the exchange transfusion will give the better results. Okay, what is the mechanism? That we all know there is a blood-brain barrier, and unconjugated bilirubin will cross the blood-brain barrier and can cause the damage to the basal ganglia, but not the conjugated bilirubin. The most of the bilirubin available in plasma, if it is not to the bound to the albumin, then there is a high chances that it will cross the blood-brain barrier. If it is attached to the albumin, probably it may not cross, and more bilirubin available for the exchange. That is what mechanism says. So that's what the study says. There are, I will quote the two studies. First studies was published in Indian Pediatrics 2010. It was a randomized control trial, and the result shows that mean duration of the phototherapy is significantly less, and none of the newborn requiring exchange transfusion with the child who has received IV albumin. This is a very good study. So that duration of phototherapy has been less, and there is no single child in the study which requires second transfusion. And of course, there is no side effects in both the groups. Again, we see the another study published in Indian Pediatrics 2017. It was studied. Studies group include full-term babies and late preterm babies, and most of the babies are non-hemolytic babies. And in the both groups, one group received normal saline, one group received 20% albumin. In both the groups, there was no difference in duration of phototherapy. There was no difference in the amount of bilirubin reduced and requirement of the second transfusion. So probably even Cochrane database says the role, there is no evidence to say very confidently that IV albumin has got some role in whether it is hemolytic babies or non-hemolytic babies. Then we talk about some certain adjuvants like phenobarbital or metalloporphyrins or clofibrate, whether this has got some role or not. The clofibrate, one study was available done in Egypt of clofibrate. They given clofibrate at a dose of 10 milligram per kg, a single dose prior to the phototherapy in child, and they found that the duration of phototherapy is reduced. Also, the bilirubin levels are brought down very significantly less. Few studies are available for phenobarbital, but most of the studies says okay, it doesn't make a difference. It made a difference of around 18 hours of phototherapy, not more than that. So, but there is other, considering mortality and other morbidity, there is no significant difference. And another studies in 2013 three conducted on metalloporphyrins also very not sure. They say that they may show some benefit. Most of the textbook shares or Cochrane analysis says that as far as there is no significant conclusive evidence to show that this their approval should be used as generalized. So we don't recommend them and we don't use them in most of the times. They are most of the times not required. Phototherapy is most of the time required. This is another term that I came across as a partial exchange, and probably I was never knowing that this is the terminology still exists in RH incompatibility with hemolytic jaundice. What this partial exchange says that if the patient is having hydrops fetalis and if the PCV level of the baby is less than 35, that means the child is severely anemic because of the RBCs has been destroyed because of antibodies. In that child, if you try to do immediate exchange transfusion, double exchange transfusion, probably this child will not survive because oxygen carrying capacity is too low in this child because of low hemoglobin. Suppose in that child we give 50 ml per kg of RBC, not whole blood. We exchange first with 50 ml per kg of RBC, then probably blood carrying capacity or oxygen carrying capacity of the blood will improve and patient will survive to undergo double exchange transfusion. Probably very few centers must have been trying with this partial exchange, but with the new evidence available, and if we come across some hydrops baby with RH incompatibility with hemodynamically unstable, probably this one technique one should try. This is to be done with RBC and not to be done with whole blood as we are doing with exchange transfusion. And the dose is 50 ml per kg. Dose to be given, and exchange transfusion is to be done with 50 ml per kg so that there will be new RBCs present and the oxygen carrying capacity will be slightly better. So probably nobody will like to have this kind of babies showing the picture of acute bilirubin encephalopathy, or also called as bilirubin induced neurodysfunctional damage, neurodevelopmental damage. This is the baby showing retrocolis, opisthotonous posture, hypertonia, and this is the histopath diagram to show that there is a staining of basal ganglia that has occurred because hyperbilirubinemia. We want to diagnose the patient before that, and there are certain signs that we all know that there is a temperature instability, feeding intolerance, high jaundice, dark color urine. Probably the child will have got high pitch cry. There is a retrocolis, opisthotonous posture. Probably the damage has already occurred, and we have to intervene before this damage occur. For that, whenever we are discharging the patient early, less than 48 hours, ask them to take a regular follow-up, or whenever there is a high risk child, ask them to follow up with bilirubin levels of 48 hours after discharge. Probably this is the last sign. Many of us are confused whether why I am putting kernicterus is different from acute bilirubin encephalopathy. Kernicterus is different and acute bilirubin encephalopathy is different. We all know that. Just want to highlight that the kernicterus is a long-term complication that occurs because of bilirubin toxicity, and acute bilirubin encephalopathy is acute management in NSU period. Kernicterus, we all know there are characteristic features like upward gaze palsy, sensory neural deafness, dental anomalies, and athetosis, and mostly chorioathetoid type of cerebral palsy. These are the features of long-term complication and they are called as kernicterus. Whether in acute condition, we label them as acute bilirubin encephalopathy. Then again, last few words about prolonged newborn jaundice. Whenever we get a child who is more than 14 days in full term and more than 3 weeks in preterm babies with the jaundice still persistent, we have to find out whether this is cholestatic type of jaundice and then go accordingly. If it is not cholestatic, then see if it is a more than 15 or not. If it is more than 15, then only they need much evaluation. If it is less than 15, probably we can ask the child to come again after 48 hours and repeat the sample. If it is more than 18, probably, or 18 to 20, this is the child may require phototherapy, because this is not a child who was normal, and phototherapy may help in decreasing bilirubin. So even it is a 21-day child, if it is a bilirubin is 22 or 23, this child will definitely need a workup, and more common causes like Kliegler-Najdar syndrome or congenital hypothyroidism should be always kept in mind, or some other metabolic disorders like tyrosinemia, cystinosis. All these problems should be always in the back of mind whenever you see the child with prolonged newborn jaundice. So thank you. With this, I think most of the recent advances I tried to cover, but most of the things were just nostalgic. But it is good way to again go to the nostalgia and read all these books that we are reading long back. So thank you very much. I will stop sharing the
One
slides.
question, just
I will stop sharing
routine
this.
routine use of phenobarbital. Sripad.
Yes, yes. There is a
Routine
one
use
Indian
of
study.
phenobarbital for the.
There is a one Indian study that definitely show that the duration of phototherapy is reduced by 18 hours. But probably, if even if it is given in whatever type of jaundice, hemolytic or non-hemolytic, the duration of phototherapy can be reduced by 18 hours. But other thing like need of exchange transfusion, and other complication, they cannot be prevented. So probably there is no strong evidence to say that routine use of phenobarbital. Yes, but if it is a type 2 Kliegler-Naegara syndrome, probably this will phenobarb will definitely have got role. Or type 1 also, if we have recovered the child from doing exchange, this phenobarb has got some role. Otherwise, who else will like to want to discharge the child 18 hours before, whenever the child is admitted in our private hospitals? Let the child be with us 18 hours more also. We will monitor the child.
Thank you, Sripad. Wonderful talk on one of the most common condition which we encounter during our practice, and take home message that as a caregiver we should able to differentiate between physiological and pathological jaundice. If a jaundice is appears within 24 hours, or if it's associated with other elements like liftless, if it's associated with fever. Jaundice is regarding the phototherapy, and also regarding the new drugs such as IVIG, role of IVIG and role of albumin in the to decrease the jaundice, basically exaggerated jaundice, and in some RH incompatibility cases. So thank you for Sripad for this wonderful talk. Our next talk is regarding newborn care by Dr. Ramakant Patil sir. We have been taught in our undergraduate days that to know abnormal, we should know normal things first. It may be normal anatomy, physiology, or biochemistry. Then only we can differentiate or we can diagnose the abnormal things. And normal newborn is a very important topic regarding for the caregivers of a newborn baby. And to give this talk, we have Dr. Ramakant Patil, who is our executive board member of Central IIP member, presently in 2022. He is a founder of Nelson Hospital, past vice president of IMA. Present, he is also chairperson, organizing chairman of Nashik Mahapedicon. And after Nashik Mahapedicon, we know one more feather will be added to his all this list. So I request Dr. Ramakant Patil sir to start his lecture.
Whether organizers want to say something before I start my presentation?
No, sir, you continue.
Please make me co-host because the host has disabled participant screen sharing.
Yes, sir. Prakash.
Sir, you are the host now.
At the outset, I will congratulate Amravati IIP, Dr. Naresh Taide, Rajput, and Ruturaj, and also a benevolent, staunch academician, Dr. Satish Agrawal sir, Dr. Jayant Pandrikar sir, and whole Amravati team for taking this initiative of taking newborn CME, newborn care CME and symposium. My job has been made quite easy by Dr. Jahagirdar, Shripad Jahagirdar, and Manjusha Taide. She gave bird's eye view about the newborn care, particularly for generalists and medical officers and healthcare workers at primary healthcare center and urban healthcare center. So as our chairperson, Dr. Vinayak Patil, and another chairperson, Dr. Milind Baradia is there, Vinayak Patil sir has said, we should know what is abnormal to say what is normal, or we have to define normal. So what is normal newborn? So baby who is having weight 2.5 kg at the same time gestational age more than 37 weeks. His birth weight should be between 10 to 19th centile on intrauterine growth chart. And there shouldn't be any need for assisted ventilation except beyond resuscitation. Apgar score should be 7 at 1 minute and above. And there shouldn't be any need for extended Apgars. And there should not be postnatal illnesses like respiratory distress and other things which require NICU admission. Once we have defined that this is normal newborn, then we can take the care, routine care of normal newborn. And I will restrict myself to the routine care of normal newborn and common problems, if at all they are there, to address. I will like to try and address them. So before we go to a normal newborn care, in a delivery room or in an operation theater, we have to prepare for the reception of the newborn. And there should be a definite corner in a delivery room or operation theater for the newborn. As we all know, radiant warmer, resuscitation kit, pre-warmed towel is most important. Whatever linen which should be a clean washed or pre-warmed, and if sterile, it is all the more welcome. But preferably it should be a warm and sterile. And this before the baby is being delivered, mother going into second stage of labor, all this should be warmed properly under radiant warmer. So it will go to the temperature of 37 degrees centigrade, and that will definitely prevent problems and hypothermia for the baby. And if they are sterile, then definitely one of the 5 cleans will be taken care of. In addition to whatever we are seeing in this picture of umbo bag, mask, laryngoscope with straight blade 0 and 1, the mask size of 0 and 1, and pre-filled syringes of adrenaline, and all those things should be there. And more important, in addition to this, is the skilled birth attendance. At least one person who is qualified or trained in neonatal resuscitation, that healthcare worker should be present, and he should not be on call. He should be present in delivery room or operation theater. And that will definitely help in having a normal newborn care and proper resuscitation if at all required. After we have prepared and newborn is born, if baby doesn't require resuscitation, or if require resuscitation, we have to take utmost care. We will not go into resuscitation because NRP is a 2 days or 1 day program. So sorry. In addition to resuscitation, if required, we have to immediately provide immediate postnatal care, breastfeeding. We have to prevent hypothermia, infection. We have to do neonatal screening, and most important that we have to do the parent education and simultaneously doing the identification of the newborn and following the checklist, and then we can discharge the baby. So in delivery room care, what is most important, as I have uttered the word of 5 cleans. What is 5 cleans? The most important 5 clean is that we have to wash our hands properly. Then it should be a clean surface, clean towels, the clean umbilical cord clamp or tie, and the cutting is, now this is very basic, but it can be re-emphasized time and again, that it should be followed properly. Most important thing, in best of the centers, the compliance of hand washing is only up to 70%. I will request if somebody has to comment, please comment, otherwise mute yourself. Thank you. So these 5 cleans have to be followed. And once baby is delivered, we have to voice out the birth time. Then it becomes a problem that what was the birth time, and we ask anesthetist or we ask a sister or a obstetrician is busy in normal delivery and even in Caesar. So, but we keep asking. So we have to voice out loud, and everybody who hears it, even obstetrician hears it, what is birth time, and that doesn't create a poor show or doesn't, we don't have to ask somebody. And this we all know in NRP, it is warm, dry, stimulate, and position. Here, because many NRP, this thing is that they are saying warm, suction, dry, stimulate. So what I feel that it is a warm, dry, stimulate, and suction only if needed. suction only if needed. So the towels which are already warm, baby was to be received in a warm towel, it's simultaneously to be dried, and this drying most of the time attains our goal of stimulation of the baby and positioning. Suction is only to be needed. Now, once this baby was born out of normal delivery, if it is possible and we have to try and exercise that, this baby has to be kept on the lap of mother and immediately covered with the sterile warm towel, and if possible keep the skull cap so that this baby can have a breast crawl. Baby can crawl for breastfeeding and skin to skin contact is established. In case of cesarean section, this becomes a bit difficult. I have kept this delayed cord clamping after the skin to skin contact, because even if the baby is delivered vaginally or by cesarean section, we have to wait at least for 60 seconds, 1 minute to do the cord clamping. We, in a gentle way of we have to convince our obstetrician friends, and most fortunately, most of them have already been aware of the benefits of delayed cord clamping, and they are not in a hurry of clamping the cord. But in case of cesarean section, it becomes difficult for them to hold the angle of uterus from bleeding, because the bleeding at that time is many times very torrential. They have to hold the angle of uterus and apply the clamps and then hold the baby. So as early as possible, if the sterile towels are there on the mother's abdomen or towards chest or in between the two legs, baby can be kept in a prone position and let the cord pulsations to stop at least, or wait for 60 seconds. And delayed cord clamping has grade 1A evidence for being advantage to all the babies. For whatever premature babies, it used to cause polycythemia, that has been again negated by many studies, and delayed cord clamping is now standard of care. It has been, before the doctors were there, the cord clamping was done. Once it was stopped, vasoconstriction was appeared, and used to take 1 to 3 minutes. So this blood is from placenta in the cord is baby's blood, and baby should be receiving this blood. So delayed cord clamp has to be meticulously, religiously practiced, and we have to request our obstetrician friends and plead them to practice this delayed cord clamping. How the cord to be clamped? Cord to be clamped from the umbilicus at least 3 centimeters, and beyond clamp at least 2 centimeter to 3 centimeters should be left there of the stump of the cord. And this cord should not go below the nappy. It should be always be there above nappy, so soiling will be prevented. And if the cord clamps are not available, then cord has to be tied with the surgical tie, which is a sterile. So once we have clamped the cord, after 1 minute, and if cord has been cut and the cord clamp has been applied or tie has been tied, then we have to establish the breastfeeding. And we have told already that we are going to keep this baby on mother's lap. We let the baby have a breast crawl and we'll try and do for breastfeeding, or we have to help to latch the baby on the nipple or areola and try and give the breastfeeding. Once we have given this skin to skin contact, tried breast crawl, breastfeeding, then baby is taken under warmer because baby was already covered in these sterile towels which were pre-warmed, and then baby has to be taken under the warmer. Here the stomach wash is not to be given if there is a history of polyhydramnios and the stomach bubble is not there. In that case, you will just put in a infant feeding tube, establish that it has gone into the stomach and the air could be heard or aspiration could be is there, but we need not aspirate the stomach content. Whatever we have aspirated, we have to push it back. And here only in presence of pediatrician and a operation theater nurse, we have to tie the identification tag. We should mention the name, complete name of the mother. Otherwise, some mother's same surname and first name will be there. That can create problems in a busy operation theater or labor rooms. So complete name of the mother, sex of the baby, birth time and date. If these things are to be are put in on identification tag, it will definitely prevent a chaos or whatever problem which is going to be there. Fortunately, in our country, there is a 24-hour rooming in practice, and which is a definite boon for our cultural and religious practices. We need not have to do that, but wherever there is some queries about rooming in, we have to be reassuring way that we have to promote that rooming in has to be done there. So once we have done all these things, what we have to do is that we have to promote early breastfeeding and exclusive breastfeeding. Weight check. I did not say weight check in weight check can be delayed for 1 hour. So all things have to be done first and then weight check. We have to meanwhile continuously maintain the warm chain. Detailed clinical examination has to be done and we have to screen for malformation. This will and discharge summary and parent education will cover the care of normal newborn or essential newborn care. So we have already discussed about breast crawl. We have discussed about covering the baby with the mother and if possible putting the cap on baby's head, and we can delay weighing and giving a vitamin K which have already been covered. So how we are going to promote the breastfeeding in these babies, that we have to initiate breastfeeding at early as possible. In first 6 hours baby is quite awake and these 6 hours have to be taken advantage of, that every 2 hourly we have to give breastfeeding. We can tell that in first 24 hours the breastfeeding will may be given every 2 hourly, but after that it should be a demand feed rather than a scheduled feed. Most of the time, as per advice of pediatrician, mother wakes up the deeply sleeping baby to breastfeed and baby doesn't take breastfeed and mother comes and complains to us that baby is continuously sleeping. So where we have to tell that the sleep wake cycle and the circadian rhythms, at least once in 24 hours baby can sleep for 4 hours. If baby is not waking up after 4 hours, after 48 hours in normal newborn, not in case of preterm, if baby does not wake up after 4 hours, in between if mother is anxious, every 2 hours she can see whether the baby's color is good, perfusion is good, the toes and palms and soles are pink and respiration is good, mother can let the baby sleep, and when your baby wakes up then mother should take for the breastfeeding. So this way we can establish the scheduled feed than the demand feed than the scheduled feed. Scheduled feed, many times baby is not awake or baby is not in a hungry and doesn't take breastfeeding properly. Only first in 24 to 48 hours we can say that scheduled feed of every 2 hours should be given, and in first 6 hours when child is quite awake because of the stress of delivery, baby can definitely properly latch to the breast and bonding can occur in mother and baby and the breastfeeding can establish properly. How can we decide about the duration? I mean to say, what about duration is that how long the baby should feed on the breast. Most of the time baby empties the breast in 2.5 minutes on one side and baby feeds for 5 minutes on one breast and 5 minutes on other breasts. So do not remove the baby, because there is initially there is pour milk concept, that is it is rich in water and sugar which quenches the thirst and the hypoglycemia, or the sugar is being given rather than calling it as hypoglycemia, and the hind milk is containing more of a protein and fat which helps in gaining the weight. So complete breastfeeding on one side, and then once baby leaves, then mother has to hold the baby on other breast, and next time if the on first time baby is started with right side, then on left side in the next breastfeeding episode mother has to take. So this way whatever concepts of mother are there, that this baby takes feeding on only one side, only on right side. So we have to empathetically tell mother that if first time in the morning you have fed baby on right side and then hold on left side, the next time when your baby wakes after 2 to 3 hours, you make the baby latch on left side first and then on right side. So this way it will be equal breastfeeding on both the breast, and mother will not complain about the feeding on only one breast. Duration, any baby who is suckling more than 20 minutes, we have to find out the cause. Most of the time this baby is making it using it a pacifier, or baby is not, if not gaining adequate weight, then or not passing adequate frequency of urine or stool volume in that case and not gaining weight, then it likely to be a poor breastfeeding or inadequate breastfeeding. So adequacy, how we are establishing the weight gain at least 500 grams in a month or 20 grams in a day, or at least more than 150 grams in a week. If the weight gain is there, baby is passing urine more than 6 to 8 times, and if it is not dark and scanty amount, and if baby is passing watery yellow stools which are usually loose and the volume is good, in this case we can definitely say that breast milk is adequate. And if there is any uh, uh, confusion in mother's mind, we have to clear it empathetically. And exclusive breastfeeding has to be practiced, and in cases where in latter after the maternal leave of 3 months or 6 months, if mother wants to breastfeed the baby and express breast milk, it has to be promoted. And we have to tell that after 6 months also, if mother is going for working and going for 8 to 10 hours, she can express her milk. This expressed breast milk can be kept at room temperature for 8 hours and in refrigeration for 24 hours. And if this milk is refrigerated, it did not be warmed again. It has to be just thawed and on a kitchen table or like that. So these concepts, and most of the time the traditional practices like the nose will not be growing proper, it will be flat or like that. So many times mother holds the breast or nipple in the 2 fingers, so baby cannot latch properly. The baby, the areola, only the margin of areola should be seen about the around the mouth of the baby. Whole nipple and the bite should be on the areola, not on the junction of the nipple and areola. That will prevent sore nipples and pain to the mother, and this way it will definitely promote the proper breastfeeding. And this mother, if is not comfortable in sitting position, most of the time grandmother, maternal or paternal, just coax this mother to sit in the sitting position, breastfeed the baby in sitting position. We have to again gently tell them that whatever baby, as long as baby is feeding well, mother is comfortable, whatever position baby and mother is comfortable, please promote that for the breastfeeding. And last thing is about maternal diet. We have to tell that there is diversity world over in the diet, but there is no diversity in the composition of milk, of mother's milk. So no maternal diet will cause any problem in the baby, unless until some diet which is causing problem to mother, then it may cause problem to baby in direct way, but it will not be excreted as it is. So there shouldn't be any restriction. Mother should be given whatever she feels satiety is fulfilled. This way, I have taken more time on breast milk and breastfeeding, but it is one of the most important part after initial resuscitation and initial delivery room care, the establishment of breastfeeding. Whatever problem we are all well versed about this syringe and suction techniques, but what I find, didn't find any studies about this nipple puller, but these syringes are very painful to the mother. Those are not being done gently by sisters or healthcare providers, and rarely pediatrician or obstetrician sits in front of mother to take how to explain about this flat nipple. But if this nipple puller, which are can be sterilized in boiling water, and this can be applied continuously for 24 hours below the gown of the mother, and this doesn't cause any pinch and pain on the mother's flat nipple. And every time whenever mother is try to breastfeed, this can be removed and kept in the boiled water or sterile water for cleaning, and it will not get infected. So this definitely helps in 24-48 hours, which is not retracted grade 2 grade 3 retracted nipples or inverted nipples. This definitely helps in flat nipple and enhances and promotes breastfeeding. Most important point about is prevention of hypothermia. We have taken care in delivery room and postnatal ward. We are going to take care by providing, when our baby is kept for skin to skin contact, we are covering the baby with the cap and the warm cloth and surgical towel. In postnatal ward, fortunately, we are doing grooming in, then baby is always covered with the mother. So hypothermia in normal newborn is not a problem. Prevention of infection, this everybody knows, but still I will like to re-emphasize the proper hand washing and what are the methods. So single most important factor is in prevention of care is most important factor is frequent hand washing, and compliance is poor. As I have told, in most best of the studies, only 60 to 70% compliance of hand washing is there. We can prevent infection in proper hand washing. The cord care, we now the neonatal NNF guidelines say there is no need of putting any powder, anything application, alcohol application or anything. Just keeping clamping it with the sterile clamp and cutting with the sterile blade or scalpel, and then nothing to be applied on that. Let it dry. Only take care that it doesn't go below the nappy belt and doesn't get soiled. The clothes should be clean, sun dried and washed properly. Utensil, whatever if required, those are not required, but if required for express breast milk, it should be clean utensil. And exclusive breastfeeding should be promoted. And if caregivers in addition to mother are there, they have to be promoted to do frequent hand washing. What about bathing? Because many grandmothers and auntie and all these are, there is a blood stain. We have to explain them that we are removing whatever is removable by sterile towels. Rest will be taken care of in next 24 hours when we are going to give bath. Need not give bath for first day unless until on religious ground. It also to be given after 6 hours. It should not be a vigorous bath which is given in our country. It should be a swaddling and gentle bath. We have to put our hand in the water. It should be tolerable to us. Temperature should not go more than 38 degrees centigrade. It should be 37 to 38 degrees centigrade. And gentle wash bath should be given. Should not be, the bath should not last more than 5 minutes. Whatever traditional practice of giving the bath on extended legs of a mother or thigh, the baby should not be put in a prone position and the head should not be towards ankle, but the head should be towards the knee of the bath giver and not towards the ankles of the bath giver. So that way the baby doesn't slip off from the legs and doesn't have any trauma. So bath is this way. We have should not try and remove the vernix as well as the protection which is there. We see most of the time the sterile towels, the vernix gets removed within 6 to 8 hours. We should not try and vigorously try and remove the vernix. Most of the time healthcare workers, sisters or like that, they try and remove this vernix. So using of the diaper can be promoted, but only thing every time we have to tell them that it is to be sterile and if disposable and all these things, you have to see whether it is wet or soiled for every 1 to 2 hours and has to be changed. Should not be kept for 4 to 6 hours, 8 hours like that. And whenever you are cleaning, if you are should not use the alcohol wipes. If at all wipes to be used, that should be used for draping dry and not the rubbing. That may not, that will cause the injury. Should not apply anything in the eye like kajal or giving honey, pre-lactal feeds, and all things should be avoided, which are harmful for the baby. And once we have done all these things, exclusive breastfeeding, everything has been done, then we will doing the newborn screening. And what is important, everybody has his share of hits and misses. And everybody, the pediatrician or a neonatologist, and best of the neonatologists have must in his life of 10-15 years missed once at least imperforate anus. So we have to carefully every time we have to see for polydactyly, cleft palate is missed many times. I have seen pediatrician missing the cleft palate and even meningomyelocele. Fortunately, myelocele or meningomyelocele is not common because of sonography and imperforate anus. And this particularly has to be done meticulously. So in newborn screening, dysmorphism, malformation, pulse oximetry screening, jaundice, which is elaborately covered by Sripad. Then for dysplastic hip, we have to see for red eye reflex, hearing screen, and other laboratory screening if required. I already told about this, whether there is a polydactyly, and if anything is there, we have to disclose it gently. We have to always say that baby is fine, baby's weight is so much, baby's color is good, baby is crying well, we can try breastfeeding. But 1 or 2 problems are there. If at all it is there of like a cleft palate, we have to tell them. If it is a polydactyly, claw hand, if you suspect neonatal Down syndrome, then we have to disclose it in empathetically and should not tell that give a judgmental statement, but say that we will have to investigate and take opinion of 1 or 2 more people. This way they do not get shock of their life, relatives and mother. So this is important. Now everybody knows that this pulse oximetry is no more a instrument, but it is a part like stethoscope in your clinical examination. When we should do pulse oximetry, it should be done 24 to 48 hours. Usually at birth, many times we have to take care that in first minute the saturation may be only 65% to 70%, and every minute the saturation goes on increasing. So in first half an hour, 1 hour, do not rely too much on pulse oximetry. If the child is crying well, Apgar score is more than 7. At that time, don't go on readings of pulse oximetry. You will be unnecessarily giving oxygen to the baby, unnecessarily overstimulating to the baby. If the Apgar score is good, activity is good, perfusion is good, then pulse oximetry in first hour should not be done. But if we are discharging the baby within 24 hours, then at least 12 to 24 hours we have to do the pulse oximetry screening. And what is important in pulse oximetry screening, we have to do at least 2 limb, right upper limb, right lower limb, and left upper limb. If the pulse ox saturation will tell us that whether there is a preductal productal differentiation is there. Then if the saturation is less than 90%, we have to repeat this pulse oximeter reading after 20 to 60 minutes. Again, if it is less than 90%, we have to repeat third time. And if it is less than 90%, we will go for the echocardiography. If the saturation difference is more than 2% in right upper limb and right lower limb, that will tell us that this is a differential cyanosis pre-post ductal. And here in full-term babies, chances of persistent pulmonary hypertension chances are there. And if the difference is more, then and if there is a saturation is low, then it can tell us that whether there is a differential cyanosis with cyanotic heart disease. So this is jaundice has been covered very well, and the transcutaneous bilirubinometry, and in first 24-48 hours, if the bilirubin is more than in high risk zone in Bhutanese chart, it will definitely forearm us and forewarn us that this baby may have exaggerated neonatal jaundice. This is for dislocated hip, the Artolini and Barlow's maneuver. Artolini is for slipping in of the femoral head, which is already displaced. In Bartolini, we are easily trying and dislocating it out of acetabulum. So these are the two maneuvers. Red eye reflex, the retinoscope has to be used, which is kept at 50 centimeter distance. It is usually that retinoscope is kept at +2, and the light is kept on the put on the baby's eyes. And there should be red reflex. If it is a white or if it is a black, if it is not equal, this will indicate that there is a congenital cataract. Hearing screening can be done by autoacoustic emission, OA screening. If it is a pass, then there is no problem. If it is a refer, we have to repeat it again. I have already told that we have to do the at least TSH screening, and we have to do examine for malformation, which we have already covered. And in addition, if it is affording, then we have to do the other tandem mass spectrometry screening, which will tell us about the hemoglobinopathies and phenylketonurias and galactosemias. If it is possible, we can do it on the day 3, day 4 before discharge for the in addition to thyroid screening. But thyroid screening on cord blood or at 72 hours is a must. It is the most important preventable cause of mental retardation. We have covered all these common problems. Still, whatever common problems are there of posseting, we have to explain to the mother that proper breastfeeding is important. There should not be any munching noise which prevents unnecessary swallowing of the air. The stool frequency will be 6 to 8 times. We should not worry about it. Exaggerated gastrocolic reflex. Most of the mother and grandmother come that complaining that the baby takes breastfeeding and immediately passes motion. So this gastrocolic reflex, whenever the milk goes in the stomach, colon and intestine get stimulated, and whatever stool is there in the sigmoid canal, it comes out. So we have to explain that to the mother. That doesn't mean baby is not digesting anything. So same thing about vomiting. As long as it is curd-like, the small quantity baby will spit it out. But if baby is gaining weight more than 150 gram in a week or daily 20 to 25 gram, then we should label it as a posseting and not the vomiting. And in colloquial language also, they have different words, but not ulti. Many in our area they say durakne, but not ulti. So grandmother many times tell it like that, and many times grandmother say it is a okra basa. So as long as baby is putting on weight, we should not bother about this vomiting. Vernix cleaning, we have already told about other things. Eye care, we are having a wonderful deliberation after this by ophthalmologist. jaundice has been covered, and evening colic and excessive cry, it is the mother's anxiety should not be transmitted to the baby. That is most important. Proper breastfeeding, burping should be there for at least 20 to 30 minutes. That burping for 6 to 8 burps will definitely prevent gaseous distension and evening colic in the baby who is swallowing excessive amount of air. Evening colic will require many times the calmness of the mother, proper feeding, and acceptance of the evening colic till the 6 weeks. And once mother and grandparents accept it, most of the time it is getting cured, or most of the time it doesn't create a problem. Other problem of excessive sleeping, I have already told that if the baby sleeping, baby will be sleeping in 24 hours for once at least 3.5 to 4 hours, and more than 3 hours once, and then every 1.5 to 2 hours and 2.5 hours baby will wake up for the feeding. Baby may sleep in daytime. At that time mother has to be told that you have to sleep at that time, so you will have energy to be awake with the baby in night when baby is not sleeping, because circadian rhythm sometimes take up to 3 months. Baby will be awake more in night and sleeping more in the daytime. So this excessive sleeping has to be properly explained to the mother. If baby is sleeping in daytime, try and catch some nap in daytime, so you will be enthusiastic in feeding the baby at night time. Mastitis neonatal, because of hormonal effects and sometimes because of massage and dye, nothing has to be done. It will go away on its own. The required vaginal secretions also doesn't need any intervention. Only while bathing, the warm water has to be put and doesn't have to be cleaned with wipes or like that. May like to cause more of a urinary tract infection. The transient setting sun sign, which is usually present up to first week, does not need any intervention if the head circumference is normal. The eye care nasolacrimal duct, we are going to have good deliberation on that. The positional plagiocephaly or abnormal head size, as long as occipitofrontal head circumference is normal, we should not worry about it, because of in case of twins or oligohydramnios, abnormal head may appear, but in 24 hours it becomes many times that plagiocephaly doesn't appear to be there. In cephalhematoma and caput is not in the periosteum but above that, so it crosses the sutural lines. And in cephalhematoma it doesn't crosses sutural line, and we should not diagnose cephalhematoma in first 24 hours, because it takes at least 24 to 48 hours to establish cephalhematoma. So we have to tell that if this swelling is there, it will most of the time will go away, but we will review it after 24-48 hours whether there is any cephalhematoma or not is there, and we have to explain about the chances of exaggeration of the jaundice. And other danger signs we have to explain when you are before discharging, and when we are done the attended the call, and we have done all these things about neonatal screening examination. So any earlier appearing jaundice or jaundice which is up to the palms and sole, any cyanosis which is persistent, which is resistant, or even after warming up the fifth and palm and soles, if the cyanosis is not going away, abnormal movements, lethargy, if child is not waking up after stimulation, and respiratory distress, these are the danger signs. And we have before discharge, we have to have checklist. Weight loss more than 5% in first 24 hours is a significant, and if it is more than that, I have seen 2-3 babies whose weight loss was more than 10% in 24 hours, and all the 3 babies were having renal tubular acidosis to be diagnosed. So excessive weight loss is a significant thing. The weight loss should be visually regained by day 5. The weight loss stops by day 5, and the birth weight is regained by day 10. And in preterm babies, it is usually regained by day 15. And other things that we have to do checklist is that whether the breastfeed has been established, baby has passed meconium first 12 hours, the urine has been passed in first 24 to 48 hours, and other things we have done neonatal screening. These have to be done, and before discharge we have to vaccinate this baby. Before discharge, we have to see that baby is feeding well at least 8 to 12 times in a 24 hours. There are no danger signs which we have discussed. Mother is confident in taking care of the baby and understand the need of follow-up, and danger signs have been explained properly in her colloquial language. Then we can discharge this baby. So what is important take home message of essential newborn care? The essential newborn care is low cost intervention, does not require any technological intervention. Simple cost effective intervention can save many lives, and make the newborn life colorful. Principles of neonatal care, we have said that 6 things which are there, like proper delayed cord clamping, good delivery room care, breastfeeding, maintaining warm chain, prevention of infection, neonatal screening, and education of parents. Education of parents, maternal and paternal grandmother will go in long way of having a good neonatal outcome. Thank you for your patient listening, and sorry I have extended my time at least by 8 minutes. Thank you.
Thank you, Ramakant sir, for a very informative talk on normal newborn care. So without wasting time, we will proceed to our second session. Second session will be chaired by Dr. Bardia sir, Milind Bardia sir, who is a senior pediatrician from Nashik. He is alumni of JJ Hospital and Wadia Hospital. He is a Nashik IP president in 2025. He is a chairman of Maha Neocon 2018, founder president of Nashikon conference. At present, he is the chief organizing secretary of Mahapedicon 2022 and joint secretary of Maharashtra IIP. Our second chairperson is Dr. Manisha Kasture madam. She is a senior pediatrician from Amravati. She is a consultant pediatrician at Parisot Hospital. I welcome both of you, sir. Kindly chair the session.
Thank you.
Take over, sir. Thank you.
Should I start, madam? Introduction
Yes.
of.
Yes, sir.
Thank you, RD sir. First, I would like to congratulate you. You have made this normal newborn topic very simple.
Milind, you are not audible. You are muted.
Can you hear me now, sir?
Yes, yes, now.
Yes, yes.
Thank you, everyone. And first, I would like to thanks RD Patil sir to making this topic, that normal newborn, very simplified ways. I remember during the residency at JJ Group of Hospital, Y. Kamdekar sir used to say always common things are very common and uncommon things are very uncommon. And to diagnose the normal things, it requires lots of skill. Thanks, sir, for making this topic very. Now, moving to the next topic, that is the ophthalmic care in the newborn. Can you share me the slide of introduction of Dr. Khandelwal, sir? I will invite Dr. Ajay Khandelwal, sir, for his speech on the ophthalmic care in the newborn. Over to you, sir.
Hello.
Hello. Dr. Khandewale sir is a leading ophthalmologist from Amravati. After doing his graduation and post-graduation from Government Medical College, Nagpur, he has worked at various hospitals at Mumbai and also at Maldives as a consultant ophthalmologist. He is a private practitioner in ophthalmology since last 20 years and has been faculty in various conferences, participated as guest in various live TV shows. I welcome you, Dr. Khandewale, sir.
Hello.
Hello, sir.
Am I audible?
Yes,
Yeah.
yes.
Hello. Am I audible?
Yes, yes, sir.
Yes. Let me clear one thing. I am Dr. Ajay Khandewale, not Khandelwal. Thank you, Amravati Academy of Pediatrics, Dr. Pandrikar sir, Dr. Satish Agrawal sir, and Dr. Manisha for giving my introduction and giving me this opportunity to talk in front of you. Today I am going to talk on ophthalmic care of newborn. Now let us see what are the common eye problems arising in neonates. They are conjunctivitis, congenital dacryocystitis, congenital cataract, congenital glaucoma, retinopathy of prematurity, stimulus deprivation lesions including congenital ptosis, corneal opacity, strabismus squint, high refractive errors, and last but not least is the foreign bodies and injuries. So role of frontline barriers or pediatrician who are first seeing the child is, first eye checkup should be done at birth along with the Apgar score. If Apgar score is less than 7, special attention should be given to the eye. After birth to 1 month of age, the following of light and fixation develops. So at birth, what you have to check is pupillary reflexes, development of eyeball, blink test, and as Patil sir has mentioned, Bruckner's red reflex by ophthalmoscope or retinoscope. Why this examination is important? During infancy, from 2nd or 3rd month of life, binocular vision and eye coordination develops. And 2nd to 3rd year of life, best time to assess the visual acuity. Now, one important question is how to assess the vision in neonate. There are 3 ways to assess the vision in neonate. First is optokinetic nystagmus, second is visual evoked potential, and third is at home by following the simple toy or light. The optokinetic nystagmus is generated in child. As you can see in the picture, a drum which is on which the alternate white and black stripes are painted and which is rotated in front of the neonate's eye. And this nystagmus is noted, and the fast phase of this horizontal nystagmus will be opposite to the direction of the drum. And if eye is saccadic, if you can note the saccadic movements of eye, that clears that the child is having vision. Second is visual evoked potential. This is the potential generated in response by the visual cortex in response to visual stimuli. There is a large representation of macula in occipital cortex, and if anything wrong between optic nerve to occipital cortex, visual evoked potential will be abnormal. Third and last thing will be at home. When child is lying down, a simple colorful toy, as you can see in the picture, or torchlight, if you will move to and fro in front of the eyes, then you can note the eye movements of the neonate. Now let us discuss some common problems arising in neonate. And first of them is the conjunctivitis. High alert should be any secretion or watering immediately after birth or during first 2 to 3 weeks is abnormal, because secretion of the tears starts generally at the 2 to 3 weeks of life. The conjunctivitis, which is usually bilateral, discharge initially is watery or mucoid. In acute conjunctivitis, it may be purulent, mucopurulent, or hemorrhagic. Now coming to the important infection of eye, that is ophthalmia neonatorum. It is a bilateral purulent conjunctivitis occurring in newborn within the first 3 weeks of life. The etiology may be gonococcus, B. coli, pneumococcus, staphylococcus aureus, or streptococcus hemolyticus. Genital virus in mother's birth passage is one of the reasons for it. Mode of infection is during birth. Clinical picture is same in adults, as it has stage of infiltration where there is a lot of pain, intense pain, congestion, edema of the lid, and the signs and symptoms will be pronounced. In stage of blenuria, there will be discharge will be purulent, and in stage of healing, all the signs and symptoms will regress. Diagnosis is by conjunctival swab. Fortunately, most of the deliveries are conducting in government or private hospitals, so the incidence of ophthalmia neonatorum is quite reduced nowadays. The treatment is cleaning of lids with the soft stick. Broad spectrum antibiotics and corticosteroid antibiotics should be instilled 1 hourly or 2 hourly, depending upon the severity of the infection. Sometimes the neonate child may require systemic antibiotics also. Eyes should be kept open and padding should be avoided. as it may give rise to the formation of ulcer and opacity. Now, another coming to next problem is congenital dacryocystitis. The incidence of congenital dacryocystitis is almost 20%, which arises due to failure of canalization of nasolacrimal duct. As in this picture, you can see in each lead punctum are present in upper and lower punctum, which opens into the canaliculus, that is upper and lower canaliculus, which joins to form common canaliculus, which opens into lacrimal sac. And dacryocystitis is the infection of lacrimal sac. This lacrimal sac ultimately opens into nasolacrimal duct and which open into inferior meatus of the nose. The lumen is being blocked by the epithelial debris, and which is generally usually bilateral. Watering and purulent discharge is there. Pressure on the sac gives regurgitation of mucopurulent material. Acute attacks are quite rare. So here one important point is, while giving pressure, it should be exerted on the sac, lacrimal sac. So treatment of congenital dacryocystitis involves mainly, as you can see the picture, the lacrimal passage massage is indicated, where the mothers generally do the massage very lightly. The importance of the giving massage is massage should lie on the where the lacrimal fossa or lacrimal sac is located anatomically. So pump the lacrimal sac 8 to 10 times before the instillation of drops. Clean the secretion. Pour the 2-3 drops of broad spectrum antibiotics. Those will be sucked inside the empty sac. Then pump again the 8 to 10 times over sac and push the fluid downward. In this way, the sac will get cleared with the infection. At bedtime, topical antibiotic ointment can be helpful. With this treatment, if watering and secretions are is not getting reduced, the probing is indicated. And the golden time for probing is from 4 to 6 months. Now, coming to one of the important visual deprivation or most commonly affecting the lesion of the eye is the congenital cataract. Incidence of congenital cataract is 0.06%. It may be present by birth as a white pupillary reflex or may be developed just after the birth in early infancy, in one or both the eyes. The opacities obstruct the visual pathway during the critical period of visual development. Below 2 years of age, result into severe grade of low vision and amblyopia. So treatment again depends upon the severity of the cataract and laterality. If the cataract is unilateral and dense, immediate surgery is indicated. If cataract is immature and if you are able to see the fundus, you can very well defer the treatment for up to 3, 4, 6 months, where the IOL implantation and visual rehabilitation is quite easy. But if cataracts are dense and bilateral, most of the studies have proved that congenital cataract babies operated before 8 weeks of age have a better visual outcome. Another important observation is that there should not be difference of more than 1 week between the surgery of both eyes. Secondary IOL implantation can be performed at the age of 2 years. Role of IOLs in management of congenital cataract. IOLs are playing very crucial role in the management of cataract surgery. Ideally, it was indicated, old school of thought says that it should be done between 1 to 2 years of life, 2 years. But however, many surgeons implant IOLs from 6 months to 1 year as well, but cannot be done below the 6 months of age. Here you can see the bilateral mature cataract, and here you can see the intraocular resilience, which is being implanted inside the eye. Implanting IOL at less than 6 months of age is controversial because IOL power calculation is difficult for this age group, carries the risk of severe postoperative inflammation and PCO, which may need other surgeries and may affect the vision permanently. Future growth of eye affects the axial length and keratometry reading, which may result in unexpected refractive error and causing amblyopia. So to avoid these complications, the IOLs are indicated from 6 months of age. And nowadays, with primary IOL implantation, primary posterior capsulorhexis, and entry vitrectomy done at this time of primary surgery only, so that the chances of PCO formation and further complications are reduced and visual rehabilitation is quite easy. Now coming to next important anomaly is the congenital glaucoma or buophthalmos. Why the name buophthalmos? Because the eye look like bullseye. Incidence of congenital glaucoma is 0.01%. Age is congenital and present at the birth. Since boys are more affected than girls, usually bilateral and 80% of cases. Here you can note in the picture can see the enlarged eyeball with cloudy cornea. In the bottom right side bottom picture, you can see the basement membrane is broken there. So high alert and signals are bilateral watering during early days of life. within 2 to 3 weeks after birth without any signs of inflammation and redness, but with photophobia and raised IOP. So important differentiation point is there will not be any lid edema, congestion or intense redness, and loss of red reflex will be there. So clinical signs are there will be enlargement of eyeball with corneal edema, megalocornea you will note, tears in the descemet membrane will be present. Also, there are certain associations, that is von Recklingen's disease, facial angioma, that is Sturge-Weber syndrome. Diagnostic criteria is clinical only, enlarged eyeball with raised intraocular pressure over the lid, edema or linear opacities of cornea, and if fundus is visible, you can see a cupping of the optic disc is seen. Treatment is mainly surgical because medicine doesn't work in congenital glaucoma. Goniotomy or trabeculotomy is indicated, and if the patient is not responding to trabeculotomy only, with conventional trabeculectomy with the help of mitomycin C is indicated at tertiary centers. Now coming to most important topic is retinopathy of prematurity. The leukocoria means white pupillary reflex. Various differential diagnosis of white pupillary reflex are congenital cataract, retinoblastoma, persistent hyperplastic primary vitreous, toxocariasis, Coats disease, retinopathy of prematurity, coloboma of the optic disc and retina, and large retinal detachment with retrodental fibroplasia. Early referral, any of these causes, early referral is the key. Now, coming to ROP is the leading cause of visual impairment and preventable blindness in children in the world. High birth rate of preterm babies, that is 1 to 2% in India. Thanks to a lot of efforts and hard work of our pediatricians and pediatric friends, because of their constant efforts, the better survival rate of is there in preterm and low birth weight babies. But that has increased the burden on the ophthalmologists, and so the screening program of 100% lack of 100% coverage. So gestational age less than 30 weeks and birth weight less than 1,500 grams are most important risk factors of the development of ROP. Magnitude is around 3.5 to 5 million premature babies born every year in India. That means almost 50 lakh babies. Incidence of some form of ROP is 37 to 54%. 7 to 15% will need some form of treatment. Now, coming to pathogenesis of retinopathy of prematurity is high oxygen reduces the angiogenic factors and delays the physiological retinal vascular development. Another thing is high oxygen damages the existing normal retinal blood vessels and compromises the normal vascularity. Hypoxia retina secretes vascular endothelial growth factor from the abnormal blood vessels, that is the neovascular blood vessels, leading to new vessels bleed, leading to vitreous hemorrhage. When this vitreous hemorrhage organize and form the fibrovascular component, giving rise to traction and causing the retinal detachment. Now screening and home to screen. All the preterm neonate born less than 34 weeks of gestation or less than 1750 grams of birth weight, or all the babies born between 34 to 30 weeks of gestation or 1750 to 2000 grams of birth weight if they have any risk factors of ROP. So what are the risk factors of ROP? They are anemia, septicemia, respiratory distress syndrome, twins, blood transfusion, poor weight gain, intraventricular hemorrhages. Screening when? First retinal examination should be performed not later than 4 weeks of age or 30 days of life for infant born less than or equal to 28 weeks of gestation. Infant born less than 28 weeks or less than 1200 grams of birth weight should be screened as early as 2 to 3 weeks of age to enable early detection of aggressive ROP. Any eligible baby for ROP screening must be screened before 30 days of life. These are the National Neonatology Practice Guidelines. Screening, how the screening is done? By trained ophthalmologists with indirect ophthalmoscopy. For this, a vitreoretinal specialist is required. It can be done by a general ophthalmologist, technician, or optometrist who are trained in red cam imaging, so that the images are taken on red cam and which are interpreted by ophthalmologists as by trained for ROP treatment, and the treatment guidelines are given by him. Where? In NICU for admitted babies or in OPD for the discharged babies. Now, what precautions you have to take while doing the examination of ROP patient? Dilatation is, you have to instill the special drops for it. They are dilated with phenylephrine 2.5% and tropicamide 0.8%, available commercially as a Tropac P. Topical anesthetic is instilled. Pediatric speculum is applied. your face should be turned toward the quadrant to be examined. Thin infant depressor should be used for the examination. Documentation and communication. One of the important thing is most of the litigation and cases are pending for treating ophthalmologists as well as pediatricians who are handling such type of babies. Because most of the babies, if documentation is not proper, and even after explaining the risk factors, parents cry foul and they lodge cases against all our dear friends, pediatrician and ophthalmologists. So record on ROP sheet with diagram, one copy with NICU and one copy with ROP team. RETCAM images should be stored and properly saved. ROP card should be given to mother for discharge babies with the date and time for next OPD visit, and they should be told and informed verbally also. Now for documentation, retina is divided into various zones. Zone 1 comprises of twice the radius from optic disc to fovea up to the macular involvement. Zone 2 is nasal involvement to the temporal to the equator. Zone 3 is residual crescent anterior to zone 3. Now, for the treatment purposes, the ROP is divided into various phases and stages. Phase 1 is compromised physiological vascularization, and in which the stage 1 is demarcation line and stage 2 is ridge. Here you can, in this picture, you can see the demarcation line. On the left of the demarcation line, you can see the avascular retina, while right is the vascularized retina. When this demarcation line becomes thicker, that is known as ridge. Again, differentiate between vascularized and avascular retina. This thickened ridge gives rise to traction on the retina, giving rise to the fibrovascular formulation. And phase 2 is vasoproliferation, where the extra-retinal fibrovascular proliferation perpendicular to the retina is exerted. Phase 3 is fibrovascular phase, which is this traction giving rise to partial retinal detachment, and stage 5 is total retinal detachment, which here you can see the grayish white reflex inferior to the in the inferior part, that is a tractional retinal detachment because of the traction on the retina. These are the various stages again of the retinopathy of prematurity. In stage 1, where the mark arrow is indicated, that is a demarcation line. In stage 2, you can see the thickened ridge. In stage 3, you can see the fibrovascular phase, and stage 4 is a plus disease. What is a plus disease? Marked dilatation and tortuosity of the retinal vessels with vitreous haze, engorged iris, and rigid pupil. So when to stop screening? When full vascularization of retina till ora serrata is completed, screening should be continued, and it usually complete by 40 to 45 weeks of the life. Then regression of ROP is noted. Now treatment is again divided into 3 categories, that is the laser, anti-VEGF, that is anti-vascular endothelial growth factor injections, and surgery. Type 1 ROP is urgent on the same day of screening or as soon as possible. Aggressive ROP, that is where there is a poor pupillary dilatation, rubiosis, that is a neovascularization of iris or vitreous hemorrhage. Anti-VEGF injection should be immediately given. Surgery that is given for stage 4A and stage 4B or as soon as possible. For stage 5 with closed funnel, surgery may not be helpful, and the prognosis of surgery is very poor. Even after this aggressive treatment and treatment taken at time, long-term sequelae may come. Those are increased incident of squint and amblyopia, myopia, retinal detachment, and glaucoma. So long-term monitoring is essential for the factors mentioned above. Now, one of the important entity present at birth is the squint or strabismus. Squint is a condition when one eye always deviates from the fixation point, and squint can be divided into latent squint or manifest squint. Latent squint is a squint which is present for some period of time, and otherwise the eyes will remain straight or parallel. Manifest squint is eye will be deviated for whole day. So, in infantile esotropia or congenital esotropia, which is present within first 6 months of life. The commonly seen in mental retarded or brain damaged infants, that is cerebral palsy or hydrocephalus. Clinical features are fairly large and constant angle. Fixation, most of the infants alternate fixate in primary position and cross fixate in side gaze. Nystagmus is horizontal. No refractive error will be, or very minimal refractive error will be there. Management, usually for congenital or infantile esotropia, management is surgical and should be performed prior to the age of 18 months. retinoblastoma. Now, coming to commonest tumor originating from the retina is highly malignant. Age is congenital but manifests within first five years of life. Fortunately, the incidence of this tumor is quite less. Sex is no difference, usually bilateral. Signs and symptoms are usually present at white pupillary reflex. Diagnosis is by B-scan ultrasonography, and treatment is by mainly enucleation as early as possible, because enucleation or otherwise the chances of metastasis and cerebral metastasis are much more. It will delay the treatment. Now, stimulus deprivation lesions, they include the congenital ptosis. Congenital ptosis may be unilateral or bilateral. Unilateral ptosis may give to severe visual deprivation in the child. In bilateral ptosis, if there is a ptosis is mild to moderate and visual axis is clear, the treatment can be deferred until the child grows older. If the ptosis is severe and levator palpebral action is poor, then the immediate surgery is indicated. If surgery cannot be done on medical grounds, then ptosis crutches are indicated for alternately for 1 hour, and then again eyes are kept open. Congenital corneal opacities should be dealt immediately. Congenital cataract, we have seen the treatment in detail. High refractive errors again gives rise to visual deprivation, amblyopia, and they should be, the glasses should be prescribed as early as possible. Now, coming to the last part of this my talk is the injuries. These involve the injuries during the birth of the child. There will be significant ocular trauma during birth, usually associated with forceps associated delivery, but rarer and can include. Now, nowadays, these injuries with forceps associated delivery injuries are quite less, but they are Descemet's membrane rupture, lid laceration, hyphema, Putcher's retinopathy, facial nerve palsy, corneal edema, and corneal laceration. Accidental injuries involving accidental injury to cornea by child's own fingernail, falling of any object, or fall of child. Foreign bodies included the dust particles may go on the cornea, may lodge on the cornea. It may go into the fornical conjunctiva. If foreign bodies are present, as you can see in the picture, if the foreign body is lodged on the cornea, it should be removed under sedation. If the foreign body is mobile and it is in the conjunctival sac, you can remove in under the topical anesthesia with the Descemet's lid retractor. Now, take home message from today's talk is conjunctivitis should be treated promptly and actively, and eye should be cleaned frequently. So eyes should not be padded and examined twice a day. In congenital dacryosis, that is pressure or lacrimal sac, along with broad spectrum antibiotics is a key point. And if it is not responding, golden period for probing is from 4 to 9 months. Bilateral haziness, watering, photophobia should raise the suspicion of congenital glaucoma. All neonates with white pupil reflex should be investigated thoroughly to rule out retinoblastoma, congenital cataract, and retinopathy of prematurity. Stimulus depriving lesions should be corrected as soon as possible. Injuries and foreign bodies should be treated promptly, as it may leave permanent corneal opacity, losing vision permanently. Thank you very much. I hope frontline warriors or pediatrician friends have benefited from my today's talk and will able to take necessary action whenever the any ocular problem arises in newborn. Thank you very much for patient hearing.
Thank you, Dr. Khandewale, for a very enlightening speech about care of newborn and the common problems which we commonly face in our practice. And you have given us a very nice guideline about management of ROP and all the problems. Thank you so much, sir.
Thank you.
Hello. I want to share my screen. Okay.
पहले मॅडमचं इंट्रोडक्शन होऊ द्या ना. Chairperson, sir.
I would like to introduce Dr. Jagruti Murke, who is a gynecologist, who is from Amravati. She has done her MBBS and DGO from Mumbai, and she has done her postdoctorate for a fellowship from Chennai. I would like to welcome Dr. Jagruti Murke.
Thank you so much, ma'am. Can I share my screen now? Prakash? Hello, I'm not able to share my screen. Okay. Hello, am I audible?
Yes, ma'am.
Okay, thank you. Okay, good afternoon, everyone. Thank you for having me here. Special thanks to Dr. Pandrikar sir, Dr. Satish Agarwal sir, Dr. Naresh Taide sir, and entire IIP team Amravati. So without wasting time, my topic is importance of anomaly scan. I'm Dr. Jagruti Murke, and I'm a fetal medicine consultant. So whenever we do a scan, and especially the first pregnancy ultrasound, that is when we see the happiness. Both the parents are happy, the doctor is happy, but this happiness is not always true. Sometimes we also have to give a little different news than they are expecting. But yes, definitely ultrasound is now an established tool in the clinical management of pregnancy. The main goal of a fetal ultrasound scan is to provide accurate information which will facilitate the delivery of optimized antenatal care with the best possible outcome for the mother and fetus. Okay. The major abnormalities are present in 2 to 3% of fetuses. Because of these abnormalities, there is increased risk of stillbirth, neonatal morbidity, and mortality. Also, there are implications for life expectancy and quality of life later in adult life. So it is very important to see them prenatally. So ultrasound provides a non-invasive, safe bedside method of assessment of the fetal anatomy. So what is anomaly scan? It is also called as a target scan or a TIFA scan. It is a detailed, systematic, and meticulous head-to-toe clinical examination of the fetus, ideally done at 18 to 22 weeks of gestation. And when an anomaly scan is normal, we can reliably reassure the parents that yes, the baby is fine, at least for the period of gestation. So who all need to be done an anomaly scan? Anomaly scan has to be offered to all pregnant women. And this is because most of these fetal anomalies occur in otherwise low risk pregnancies with a prevalence of around 3%. So very important to offer all. Other than detecting anomalies, it also helps in giving other information. They are accurate determination of gestational age, the fetal number, like a volume, placental localization and abnormalities, the umbilical cord, look at the umbilical cord, cervical length, and other gynec problems like uterine fibroids. These all things we can come to know. Now, with the, I want to also highlight a new concept with the help of this platform, that there is a model for new pyramid of prenatal care based on the 11 to 13 week assessment given by Professor Kypros Nikolidis. Now what it does, the gray one is our old prenatal care pyramid, where the care started as late as 16 weeks and the maximum care was given in the later gestation. Now the pyramid of care is inverted and the maximum care starts as early as 12 weeks. Once the 12-week scan and the assessment is done, they are divided into high risk and low risk. High risk patient requires specialist care from 12 to around 34 weeks, and if it is a low risk, then she comes again at 20 weeks. So the care has now started at 12 weeks. So as a fetal medicine person, I would also include 11 to 13 week scan. The NT scan is also a very good time to detect fetal anomalies. So we look at the baby when it is 45 to 84 centimeter. We look at the nuchal translucency, the fetal heart rate, the nasal bone, ductus venosus, tricuspid flow, and also fetal anatomy. Maximum fetal anatomy can be checked. So 50 to 60% of major anomalies can be detected. Screening for aneuploidies is done best. Twins can be best managed. It helps patients to make early informed decisions. Options for early invasive testing like CVS can be done at this stage. Also, if there is a major anomaly, early termination can be offered. It definitely needs more trained personnel. It needs better equipment, and evolving anomalies cannot be diagnosed. And when you look at heart or any extended anatomy, it's a still challenge. You need trained personnel, but it is very good to be done at that time. So when you look at potentially detectable anomalies, it depends upon the objective set for such a scan, the time allocated for the fetal examination, the expertise of the sonographer, and the quality of the equipment used. The goals are to predict structural normalcy appropriate for period of gestation, to identify severe and lethal fetal anomalies, to check for biometry, growth, and evaluation of the fetal environment and uterine Doppler flow. In case of suspicion of any abnormality, decide for further follow-up, investigations, and if needed, any interventions. The use of high-end scan equipment enhances the accuracy in several situations. There is no evidence to suggest that a routine scan or any anomaly scan is harmful to the fetus, though unnecessary exposure should be avoided using the LRA principle. All these things, after all these things, I would just want to enlighten on the importance of anomaly scan by help of few cases. This is the patient who is gravida 2 and para 1 living 1. She came for an NT scan at 12 weeks. Nuchal translucency and nasal bone, as you can see, is normal. Rest also of the baby appeared normal, but on detailed examination, obliterated intracranial translucency was diagnosed. Now, this is a marker for an open spinal cord defect, a neural tube defect, and which is a lethal condition. Immediately, a transvaginal scan was done to look better at the spine, and there was open neural tube defect was detected. And the couple were counseled regarding that, and definitely they opted for MTP. And imagining at 12 weeks they could take a decision. So again, better. That's the open neural tube defect that was seen later. After counseling the patient, they decided to terminate. But it was easy to counsel them at 12 weeks. This is a patient, case 2, 32 years, primary gravida, 18 weeks. She did not do any NT scan or screening, but on anomaly scan, there was absent nasal bone. Rest of the findings were normal. Now, we all know that an absent nasal could be a normal variant, but also be a pointer to Down syndrome. So she was advised amniocentesis so as to confirm whether baby is Downs. Luckily, the karyotype came normal, and they could continue the pregnancy after counseling, and the baby is doing good. So again, this was a good opportunity to counsel, and the outcome was good. This is a patient, 28 years, primary gravida. She came with a prior anomaly scan indicating about a normal fetal heart. So second opinion for fetal 2D echo. When we saw there was absent pulmonary veins and could also see an extra vessel in the 3-vessel view, which later on was given as a vertical vein, and it was suggestive of a total anomalous pulmonary venous connection. Now, this is an uncommon CHD, definitely, but here all the 4 pulmonary veins drain into the right heart through different routes of venous system. And this, why I'm mentioning this is one of the true surgical emergencies. Now, if you know this condition beforehand, definitely it has a good prognosis. Not only this, but any other CHD, cyanotic heart disease, if you detect beforehand, and if you keep, if deliver the patient in a tertiary care with keeping everything ready, all the team ready for the baby, then we have a good outcome for that fetus. So with systemic and meticulous fetal examination, reasonable amount of reassurance can be given to the couple antenatally. If there are deviations from normal, more detailed anatomical and evaluation and clinical follow-up can be done. Prenatal detection of anomalies, allows the couple for several options in addition to standard care. Special care during delivery can also be given. In utero, and termination of pregnancy, if it is detected before 20 weeks, can be advised. One more thing we need to remember, that late evolving anomalies may not be detected always antenatally and need to be follow up, and also after birth. Thank you so much.
Thank you, Dr. for the very informative talk on anomaly scan and the treatment protocol. Thanks a lot.
Thank you, ma'am.
Welcome Dr. Rushikesh Ghato, a young dynamic pediatrician of Amravati. He's a developmental and behavioral pediatrician. His center, Prayas Child Development and Autism Intervention Center, is a boon to our Amravati people. He has done his fellowship in learning disability and neurodevelopmental pediatrics and has certification in special education. Welcome, Dr. Ghatol.
सरांना होस्ट करून घेऊ.
आहेत सर होस्ट सर.
Till the time, the question to Jagruti Mukhe ma'am. Jagruti ma'am, you are there?
Yes, sir.
And the question is, does every pregnant woman need to undergo this anomaly scan? And second thing, how much time does it take?
Yes, sir. Definitely, every patient, every pregnant woman should have her fetus screened for anomalies. And minimum time required, again, it depends upon a lot of things. But yes, 20 minutes you should be giving ideally to every fetus for an anomaly scan. And it definitely depends upon the fetal position, what is the maternal BMI, and other factors like lighter volume and what gestation are you looking at the baby, and what equipment are you using, whether it's a higher end or a lower end, and preferably use a higher end machine. Apart from that, otherwise also you should give at least 20 minutes to every anomaly scan to look for each and every detail. It is a detailed head-to-toe clinical examination in utero.
Is it possible sometimes the septal defects, they get missed on this animal scan?
Yes, definitely. Yes, so 1 second. Sir, can you repeat your question?
Is it possible that ventricular atrial septal cardiac septal defects may be missed on this animal scan?
Yes, sir. Actually, it in fact does get missed, because actually it is both the way. Sometimes they are there and not seen, and sometimes they are not there but are falsely reported, that they look like a VSD. Especially a inlet VSD will look like a VSD, which is not there, but it is just because of the beam is perpendicular, it looks like a defect. So both is possible. And VSD can be missed because not everyone will do what we do in routine anomaly scan is a basic evaluation of heart. It's not a detailed extended evaluation. If at all we have any doubts in the routine screening, that is when we put the patient for a fetal echo. So it can get missed, but again, one thing is that missing a major anomaly is worst. A small VSD may be missed, sir. That is not the issue, and we usually don't do anything for that.
Thank you, ma'am. Thank you.
Thank you, sir.
Rushkesh.
Yes, sir. Am I audible, sir?
Excellent.
Okay, sir. Can I share the screen?
Yes, sir.
Okay, thanks. Yes. So everyone is able to see the slides or not? Please someone reply.
Yes, yes.
Okay. So we will start our today's presentation. Okay, thanks. Okay. So good afternoon, everyone. My name is Rishikesh Khato, and I am practicing as a pediatrician. And we're going to discuss the topic which is very close to my heart, that is prevention of neurodisability in the neonates. Because ultimately, neurodisability is the thing which can be prevented, or we can modify the outcomes by proper intervention during the neonatal period itself. So developmental care has been described as a philosophy of care that requires rethinking the relationships among the infants, families, and the healthcare professionals. Developmental care minimizes the stress and the shock of the environment for the neonate in order to maximize their long-term survival outcomes. So what are our aims or goals? Is to promote the calm environment and to helps to protect the rapidly developing brain, and it will also protect the sleeps and decreases the stress and may decrease the need for the pharmacological interventions also. So importance of the developmental care is summarized here, and it is important for the skeletal integrity and the postural control, sensory motor organization, and the reduced risk for the IV issues. So what happens if we don't provide the adequate neuroprotective measures? Okay, so it will lead into the longer NICU stage, increased respiratory support, delayed head control, and not only the head control, but all the motor milestones and the other developmental domains will also get delayed if we do not provide the adequate neuroprotective measures. increase the chances of developmental disorders also, and the long-term need for the physical and the occupational therapy will be there if adequate neuroprotective measures were not provided during the neonatal care. So newborn stimulation in NICU. Now we are going to discuss this topics, and this early stimulation should start as early as possible in the NICU, with special emphasis on incorporating both the parents and the medical personnel also. Stimulation given in the NICU should neither be overstimulating one or nor the understimulating. In the NICU, child is exposed to painful procedures, excessive handling, noises, and the responses which are not contingent, and these are also irregular and the inconsistent social contacts were also there, and unstable comforting mechanisms. So, prevention of disability is equal to neuroprotection in the NICU, and this concept is clear nowadays. And what are the strategies for neuroprotection in the NICU? First one is the safeguarding the sleep. Second one is the positioning for the success. Third one is the protecting the skin and minimize. And fourth one is the minimizing the stress and the pain. And fifth one is the providing the sensory integration. So we will see one by one and discuss all these things. So first one, safeguarding the sleep. So providing adequate rest and sleep may be the single most important contribution that NICU caregiver can make to improve the newborn's long-term outcome. At 32 weeks, the fetus within the protection of the womb will spend 90 to 95% of the time asleep. By term, the sleep requirement decreases slightly in duration, that is around 85 to 90% of the time. Sleep plays a critical role in early neurosensory development and impacts the memory and subsequent learning and preserves the brain plasticity also. Sleep deprivation reduces brain size and plasticity and is associated with the enduring consequences for the learning, behavior, and the function. So what we can do in the NICU to safeguard the sleep? So first one is to protect the sleep cycle. Use spontaneous awake period for routine caregiving when you are possible, and allow rest period for at least 60 minutes to complete a normal sleep cycle. Promote a quiet environment without loud noises to ensure the uninterrupted sleep, and protect the eyes from the bright lighting at all times and avoid the use of overhead spotlights. Use narcotics and the sedatives carefully, since both of these interfere with the rapid eye movement and non-REM sleep also. Facilitate prolonged skin-to-skin contact to promote the normal sleep pattern. Second one, after the sleep habits to safeguarding the sleep, second one is the positioning for the success. In utero, the fetus kicks and moves freely against the boundaries that provide the constant touch, movement, and the position feedback. When born prematurely or the critically ill, the gravity forces the weak infants into an uncomfortable, flat, and extended resting position, with the extremities abducted and the externally rotated also. The neuronal collections are reinforced that support these abnormal postures as a baseline, and developmental delay and the permanent disabilities may better. Therapeutic positioning promote the improved rest and the growth and normalizes the neurobehavioral organization. Infants who are comfortably contained are more likely to be calmer, require less medicines, and gain weight more rapidly. So these are some of the pictures of how to encourage the adequate positioning in the NICU and what positions we should avoid. So during this upper column, we can see what position we have to encourage. So we all know that mainly the infants or the early neonate can lie in the three positions: the supine, side lying, and the prone positions. Okay, so mostly the flex position should be maintained in all of this, and flex position with the supports from the blanket on the boundaries, that nesting, and the rotate the baby in different position to promote the head shaping, gross motor strengthening, and the self calming, and ability to participate in fine motor and the developmental activities. So posture should be flex, hands should be midline, and comfortably and preferably hands should be the mouth. and avoid what position we should avoid. This is the W position of the arms, M position of the legs, and the boundaries. If there are no boundaries, this is also harmful. And the preferential head turning is also avoided. And the boundaries are, if the boundaries are too small. So third one is the protecting the skin. The skin is the largest organ of the body. It makes about 13% of the weight in preterm and the versus 6 to 10% of the adult weight. Skin is one of the 5 sensory organs designed to help the protect the body by relaying the information about the environment via the sensory neurons to the brain. Sensory receptors, nociceptors embedded at the dermal layer detects and transmit the messages about the touch, pain, pressure, and the temperature also. What we can do in the NICU, that while handling the neonate, give gentle but firm touch, which is tolerated better than the stroking. Use care to minimize the noxious touch to hands, feet, and the mouth. Provide humidity for the first 2 weeks of life to reduce the transepthermal weight loss for the LBW infants. Reduce the unnecessary exposure to topical steroids and the topical solutions anyway, and the rinse of the with water if possible. Avoid skin breakdown from common sources such as adhesive removal, thermal injury, abrasions, diaper dermatitis, CPAP devices, and the pressure ulcer. Handle preterm gently and provide soft bedding to compensate for the lack of padding, but remind parents that soft bedding and the nest are safe only in the hospital setting. That we all know. Nowadays soft beddings are not recommended during the later infantile period or in the during the toddler due to chances of SIDS. Minimizing the stress. Brain development is largely shaped by the fetal experiences within the protected setting of the womb and early infantile environment and the stimulation provided. Many factors contribute to the stress for the NSU graduates, like maternal separation, exposure to repetitive and uncomfortable care during the intervention, and the painful procedures and the unfiltered noise and the lighting. Short-term stress may increase the energy expenditure and the cortisol level and cause the cardiorespiratory instability. And the long-term and repeated stress during the vulnerable period of brain development may result into permanent structural and the functional changes. So these are the strategies to reduce the infant stress. First one is the skin-to-skin care. There's the kangaroo mother care, and the second one is the safeguarding sleep that we all know and discussed earlier. And the cue-based caregiving. What is the cue-based caregiving is based upon the concept of neurobehavioral organization, and which refers to smooth balance between the infant's physiological and the behavioral system. We have to identify the stress cues, stability cues, and the self-help cues, and plan our routine interaction and the caregiving accordingly. So these are some motor stress signs that I need rest. So what are these? This is the extended posture, that normally the posture is the flex one. Posture is the extended posture, and the stop sign, my hand, yawning, wrinkled foreblade, and the splayed finger. These are the motor stress signs that the infant need rest. And what are the engagement cues? That I am ready to interact with the caregiver or the parents. That is the baby awake, quiet, and the alert. Second one is arms and leg flex, bright eyes, and the sucking movements, and the focus attention. So whenever the baby is ready to interact, we have to interact with the baby, and caregiving and the routine activities should be performed whenever the baby is not sleeping and is not showing any motor stress signs. Another is the minimizing the pain. So for many years, it was believed that the newborns were incapable of either experiencing or remembering the pain due to CNS immaturity. But it is now understood that the ability to perceive the pain at the cortical level is present early on, and the pain experience is actually prolonged and more intense in newborn, especially those born prematurely. So afferent nerve pathways which carrying the pain impulses from peripheral nociceptors to brain are fully intact by 24 to 26 weeks of gestational age. But what about the afferent ones? But the afferent nerve pathways send protective impulses back to the motor neuron and trigger the reflexive withdrawal from the pain. Unfortunately, these efferent pathways are largely underdeveloped until 35 to 40 weeks of age and continue to mature postnatally. So, if the neonate, especially about the preterm, they can experience the pain, but they cannot show the adequate responses to the pain. the brow bulge and the brows down together, as the eyes squeeze shut and the raised cheeks, as the muscle tremors and the tone abnormalities, and sleep and wake cycle changes, and the irritable and the restlessness. What we can do in the NICU to minimize this pain? So after painful procedures, sensitivity is accentuated by the increased excitability of the nociceptive neurons in the spinal cord. Allow the infant to fully recover from the painful stimulus before resuming the caregiving. Decreased physiological pain responses were noted when the containment and or swaddling were used to maintain the flexion and allow the hands to mouth for self-comforting during the procedure. Skin-to-skin contact significantly diminishes the pain responses during and after the heel sticks for the preterm and the term infant. Non-nutritive sucking during the painful procedure is thought to activate the non-opioid pathways, but the pain-relieving effects of non-nutritive sucking stops as soon as the sucking stops. Sucrose is effective in reducing the pain responses, especially when combined with the sucking and other comfort measures. It should be applied at the tip of the tongue 2 minutes before the painful procedure. Okay, and the as we all know, acetaminophen, paracetamol, and in cases fentanyl, which act as a sedative as well as the analgesic, also can be used. And last one, to improve the index, to improve this neuroprotection and to prevent the disability is the promote the intact sensory development. This is also my area of interest also, because the sensory integration procedures are mainly followed and mainly used for improvement in the children with the autism also. So sensory integration is the neurological process that organizes the sensation from one's own body and the environment and makes it possible to use the body effectively in the environment. So vestibular and the proprioceptive system. So vestibular and the proprioceptive system develops after the sense of touch. So there is a particular sequence of development of the sensory system within the fetus. First one is the tactile system, and thereafter the vestibular system, vestibular and the proprioceptive system grows up. Okay, and gustatory, and the last one is the hearing that matures. Okay, so as the main organizing systems are vestibular and proprioceptive, so we will see this at first, and later we will discuss about the tactile and the other system. So vestibular and the proprioceptive systems developed after the sense of touch. The womb provides the optimal setting for development of these senses. The secure boundaries of the uterine wall promote the generalized flexion and the gentle containment, supporting the development of the proprioception. Maternal movement and the fetal activity within the warm amniotic fluid offers the vestibular and the tactile situation. Actually, the vestibular system, there's a balance, and the proprioception helps us to realize the position of our limbs in the space. So, what are the interventions we can provide to improve this vestibular and sensory integration and to modify the outcome? The first one is to provide the containment, that is the nesting during the caregiving. Change the infant position slowly and without sudden movement, and the facilitate the skin-to-skin contact at home way to stimulate the vestibular system. Baby slings or the front carriers, the natural motion provides the plenty of vestibular stimulation. Tactile system, that's a touch temperature, pain, and proprioception starts to develop as I told earlier, that it starts to develop at around 7.5 to 8 weeks and fully develop at around 24 weeks of gestation, develop in cephalocaudal manner, and most develop of the senses in early neonatal period. And interventions, these are the gentle human touch, swaddling, nesting, maternal touch, infant messaging, KMC, and gentle firm pressure and food bracing. Gustatory system is a test. It is functional by 24 weeks of age, and interventions are oral care with breast milk and the nursing at the breast. The auditory system, which fully functional at around 32 weeks, and the term infants have preference for the sound, and preterms are very sensitive. Less than 45 decibels, and interventions that will help to avoid the unnecessary exposure of the neonate to this the sounds, the decrease the sounds and the signs to indicate the quiet is needed, avoiding being leads, and they encourage the staff and the visitors to talk quietly and avoid talking over the infant in an open call. Visual system. Structural elements of the eye form early in the fetal life, but the majority of the essential neurotransmitter mechanism and the connection developed during the final 12 weeks of pregnancy. After 38 to 40 weeks of gestational age, visual system is activated by the light and requires a variety of the visual experiences for sustained development. Actually, our visual cortex, as we all know, is in the occipital.
Unmute yourself.
Hello.
Dr. Rushikesh, unmute yourself.
Some slides are remaining. Can I continue with that? So these are the measures that we can imply in the NSU for the optimal development of the visual system. First one is the bold pattern and the strong contrast that starts with the simple shapes like squares, circles, and the black and white face shapes. Making faces, try to catch the baby's attention and make a face one can stick out of the tongue, and make an O with the one lip or raise and lower the eyebrow. That's the maximum human interaction and the that we can provide during the initial days. That will help to develop a social interaction and the language capacity with, and that will help to avoid the social communication disorder later in the life also. So moving objects, lay the baby on the lap and move the small toys or the picture and hand slowly in an arc from your baby's left to right, and then will back again. We all know the object following capacity is also not developed in the neonatal period, but object tracking can be started, or we can imply these measures from around 2 to 3 weeks, 2 to 3 months also. Olfactory system, this functional at the 28 weeks of gestation. Intervention, unscented cleaning products and the laundry and the maternal scent clothes, and the no perfumes and no foreign smells near the breast infant scent. But yes, breast milk smell or the cotton dipped into with the breast milk or the breast milk, that can be allowed, and it will help to the olfactory system. So finally, modification that can we do or in the NSU, these are the individual lighting units can be dim and adjusted to reflect. This is the summarization of all those things we have discussed. Individual lighting units can be dimmed and adjusted to reflect the cycles of the day. Reduce the unnecessary noises from the neonatal environment that is not soothing for the newborn. Gentle massage and the soft bedding promote the tactile stimulation. Try to promote the bonding whenever is possible through kangaroo mother care. And the rocking and oscillating water beds can be introduced in order to stimulate the kinesthetic or the vestibular senses. Passive exercises for the joint in order to prevent the muscle spasm and non-nutritive sucking. Okay. Apart from all these strategies that we have discussed, some of the measures those were already discussed, like the routine thyroid care and the routine screening for this ROP in the for this with this premature infant, premature and the at-risk babies, and the and the IVF screening through neurosonogram. These are the strategies which will help to prevent the disability further in the life. Thanks.
Manisha madam. Rutraj.
Yes. Excellent talk, Dr. Hrishikesh Gathod. Very well covered. We will end our second session. We will move to our next session, which is the third and last session, for which I welcome Dr. Sunil Raghuvanshi sir, who is a senior pediatrician practicing in Amravati since last more than 20 years. He is actively involved in many IIP activities. Our second chairperson is Dr. Pratima Kale madam. She is a professor at PDMMC Medical College. She's completed basic and advanced courses in MET and following medical education. She worked as an external examiner in several medical colleges under MUHS. I welcome both of you, sir and madam. Kindly take over and start the session. Thank you.
Thank you, Ruturaj. Am I audible?
Yes, sir, clearly.
Yeah. Excellent CME is going on under the able leadership of Dr. Satish Agrawal sir, Dr. Pandrikar sir. I must thank them for making me part of this CME on neonatology. The speaker for next lecture is Dr. Usha Gajbhiye madam, a renowned pediatric surgeon at Amravati. Let me introduce her. She has done MBBS, MS, IGMs from IGMC Nagpur, DNB surgery from New Delhi. She has done MCH, pediatric surgery from CMC Vellore, Tamil Nadu. And she is a fellow pediatric surgery, Southern Health, Melbourne, Australia. She has ably hold many positions like lecturer, general surgery, GMC and IGMC Nagpur. She was a SR at CMC Vellore and SR at Nair Hospital, Mumbai. She was a fellow, Southern Health, Melbourne, and she is right now a consultant pediatric surgeon at the Super Speciality Hospital, Amravati since 2008. And she is the director of her own Matru Chaya Hospital at Amravati. She has ably operated many small bachus, very small neonates in Amravati, and we are all restored to that. With this, I welcome Dr. Usha Gajbhiye madam for the talk on surgical problems of the newborn.
Thank you, sir.
Welcome, madam.
Thank you. Am I audible?
Yes.
Yeah. Can the share screen is enabled. I have logged on from two computer, one from computer and one from the mobile. So kindly make the share screen of laptop able, and from the mobile the video, because my this desktop doesn't have a camera.
Surgeon Jugaad.
Surgeon Jugaad. Yeah.
Make it full screen, ma'am.
Yeah, I'll do it. That video, you can't see me. Logged in from phone also. The video is, yeah. Anyway,
press F5, functional key F5 for full screen.
no, yes, sir, that I'll do, but yeah. Is it visible now?
Yes, ma'am.
Okay, yeah.
But
So,
you are not visible.
that's what I am asking to
can it be done or not?
make the phone also able. I'll unmute from the phone, but only video will be seen.
SS event person, can he do something?
No, sir.
Okay, then please continue with the your very important slides, ma'am.
Yes, sure.
Yeah,
Or otherwise, phone can be. I can screen the share the screen from phone also. Thought of.
Yeah, whatever you will like.
Okay, fine. Okay, we'll continue. So today, good evening, everyone. I'm going to just briefly tell about the surgical problems in neonate. So there are many surgical problems, but we'll have to just briefly review all of them, or many important only. So we start from the face to head to toe, and commonest problems we get in neonate is esophageal atresia. There are many types, 1, 2, 3, and 3B. So when you get the baby just born, most of us, they put a feeding tube to see whether it goes in or not. And if it doesn't go beyond 10 centimeter from the oral cavity, we should suspect esophageal atresia. And we get excessive secretions from mouth and frothing from the mouth in these babies. They are breathless. At times they are cyanosed because of the aspiration, and many of the times we can diagnose antenatally also. So we do X-ray if we suspect that the tube is not going beyond 10 centimeter, and the tube, if you put a rigid tube, it doesn't coil. But if you put an infant feeding tube of 8 number or something like that, it will coil in the upper pouch. So this is the commonest type of esophageal atresia. So we get coil tube in the neck on X-ray, and we do not need any more investigation beyond this, unless the child is having any congenital heart disease or any other abnormalities like anorectal malformation. So on antenatal scan, we get a polyhydramnios also. If it is diagnosed before birth, the delivery should be in the tertiary care center where the level 3 NICU is available. So also the pediatric surgery team. Surgery is done once the baby is stable, and most of the time we try to do primary repair. But if it is not possible, if the two ends of the esophagus are very far apart, we at times have to do esophagostomy and gastrostomy. If we get couples on an antenatal diagnosis with the polyhydramnias and suspected esophageal atresia, and there are no other life-threatening complications or anomalies detected, then we should counsel the would-be parents. The next common abnormality or disease we get quite frequently is congenital diaphragmatic hernia. And this is also many times diagnosed antenatally. The babies at birth will be respiratory, having a respiratory distress. And once born, it's a medical emergency, not really a surgical one, unless the baby is stable. And once the baby is stable, the surgeon comes into action. And what we is the lung on the ipsilateral side where there is a diaphragmatic hernia is hypoplastic. We get almost everything in the chest from the abdomen, and the heart is pushed to the other side, that is apparent dextrocardia. And X-ray chest, we see a lot of bubbles in the chest. The lung is pushed on the other side and slightly hyperinflated. Heart is also pushed, and the ipsilateral side, mostly left-sided congenital diaphragmatic hernias are common. So the lung is very small. And these are the findings on X-ray. For this also, we do not need any other investigation apart from the X-ray. And once the baby is medically stable, because the baby has got many medical problems also, like severe pulmonary hypertension. And then if you take the patient directly to the surgery, they won't tolerate the surgery and anesthesia. So we have to stabilize them and then go for a surgery. So surgery is repair of the diaphragmatic defect. Either you can directly close it, as seen in here. These are the sutures. And or if the defect is very large, you have to put a mesh, and it can be done in centers like us. We do it open, but in higher centers, they do it laparoscopically or thoracoscopically. And another problem related to the chest is congenital lobar emphysema. These children will present with a respiratory distress. When there is a distress, we do see chest X-ray and CT scan. Once the baby is stable, there are no major problems, we can go for a thoracotomy and lobectomy of the emphysematous lobe. Now the bowel atresias, which are common, very, very common. We get many patients every now and then. So there are duodenal atresias, jejunal atresias, and ileal atresias, colonic atresias, and very, very rarely pyloric or a pyloric atresia. So in here also we have to do optimize the patient first, take the support from the NICU, and operate once surgery is done. We have to, equally important is the post-op care, and this will give a better outcome. So starting with the duodenal atresias, these are various types. Here there is just a cord in between the two loops, proximal and distal. This is a web, and here there is a gap between the two ends. This is another picture, and what we do is antenatally, we can see duodenal atresia on the antenatal scan also. We will see a double bubble sign. And X-ray postnatally also will have a double bubble sign. These babies will present with a bilious vomiting. Most of the times they are associated with the Down syndrome. We have to stabilize the patient, put the rice tube, electrolyte imbalance is corrected. And once the optimization done is well done, we have to do a duodenostomy. Here, the proximal dilated end is sutured to the distal very narrow end. So this is the surgery which is required in duodenal atresia. This is a jejunum, very dilated proximal and the very narrow distal part. This is a web type of jejunal atresia. Now I have combined jejunal and ileal atresia. So again, bilious vomiting, abdominal distension, not past meconium, and sometime antenatal scan will give us a diagnosis. These are the how it is presented. There is a web type, there is a cord in between, there is a distance in between. There are multiple atresias associated with the this duodenal ileal atresia, and this is apple peel type of a atresia where because of the vascular accident this type of atresia happens. These are the X-rays. Will show if it is a jejunal one, it will show a few loops, and if it is a distal ileal, it will have a many loops. So this is another jejunal atresia type. So we have to investigate these cases, and once baby is optimally better for surgery and can tolerate anesthesia, we'll take patient for surgery. Mostly resection anastomosis is done, and this is type of anastomosis we do. And very rarely, if there is need of surgery, like in cases of a peritonitis and perforation, we'll do a stoma. Ileostomy is done. Now, pyloric stenosis, they present after 3 weeks of life to 1.5 months of age, and they'll have a non-bilious projectile vomiting, many times present with a severe dehydration and electrolyte imbalance. So hypokalemia, hyponatremia, and hypochlorides are also less. So we have to optimize the electrolyte imbalance, and ultrasound will have this is a pyloric muscle which is thickened. Normally it is this thin, this is normal if it is thin, but as the muscles are thickened here, it will block the lumen. And this is the ultrasound which shows a thickened wall and almost closed lumen, and this is a stomach. What we do is, once the baby is stabilized, we do a pyloromyotomy. The anterior wall of the stomach or a pylorus which is thickened, we open up to mucosa, and that is splayed apart, leaving the mucosa intact, and it will work wonders. This is another common anomaly, which is gastroschisis. If the abdomen is bowels are not matted and not thickened, and abdomen is good size, we can put it directly inside. And if it is not, then we have to sometimes put a silo. Silo is like sometimes we get a ready-made silos, or sometimes we have to do the Indian jugaad, like using a Euro bags or a blood bag, etc., and put the things inside that bag and suture to the abdominal wall and reduce it in 10-15 days. This is really a severe emergency where the bowel get twisted because there is improper fixation of the bowel to the abdominal wall. You can see here up to the mid colon, everything is twisted, and once twisted, it will reduce the blood supply, and it will cause a gangrene of whole of this bowel. So any neonate or baby presenting in the first few in a month of age, at sometimes at birth also, you have to suspect malrotation and act immediately bilious vomiting. Now here, if there is no volvulus or a gangrene, then the abdomen may not be that distended, only stomach and the part of a duodenum is distended. If the child presents very late, they'll have a huge distension, signs of peritonitis, blood in the stool, and a very sick child. So in that case, you have to do an immediate laparotomy, and this is a lad's band. We have to cut this down, and the mesentery is narrow, so we have to widen the mesentery so that the loops they fall apart, and we have to if you cut this band, it will cause the large intestine to fall on the left side. So most of the times in these cases, we do the appendicectomy because the bowel is on the other side, large bowel is on the other side, appendix is on the other side, and the later age, once the child gets appendicitis, it may be missed. So for the safer side, many of us do the appendicectomy in this operation. Now, really common presentations are of anorectal malformations, absent anal opening, or a small tract, or baby passing stool from the vestibule. So these are the in female, most of the children, they pass stool from the vestibule, and in males there is hardly any opening, so abdomen will get distended. So males, it's more emergency than the females. Here this blind end will either open into the bladder neck area or sometimes here in the bladder. So we have to do the X-ray abdomen and invertogram and see the position. So what kind of surgery the child needs. If this is a higher anomaly, the gas is, and these X-rays are done not immediately after birth, they are done almost 18 hours after birth, so that whatever the gas baby swallows will go down in the colon, and you can see the gas coming down in the X-rays. This is a intermediate type of anomaly. Here, this is a marker from the skin, and there is a some gap here. So this is the intermediate type, and here it is just adjacent to the that marker. So it is a low anomaly. And surgery depends upon high and low. High and intermediate, we do the colostomy. For the low anomaly, it is anaplasty is possible. For the females which are passing stool from the vestibule, we go for the primary repair most of the time. I do it, give some washes for few days, and then once the baby is like better and can tolerate anesthesia, we do the primary repair at birth. No colostomy in female children. So this is how the colostomy is done. It is mostly a sigmoid loop colostomy. And this is Hirschsprung disease. Babies do have a colon which is ganglionated, and this is a once, if you don't pay attention, we get this kind of a distension in Hirschsprung disease. X-ray also shows a huge number of gas shadows. This is a child with a Hirschsprung disease, and it has got a peritonitis. Some part of the bowel must have been perforated. So there are 4 or 5 types of surgeries for the Hirschsprung disease. Initially, we have to prove the diagnosis, do the biopsy either from the rectum, or if the child is very sick, doesn't have a like time to go for a rectal biopsy, and in that case, we go for a colostomy. So the ganglionated bowel is pulled down. This is the basic thing we should know. Ganglionated bowel is pulled down to the and suture to the rectum. So this is a Duhamel operation. There is a Suave's operation. Now posterior urethral valve, very common bad disease. So it's a spectrum of disease where, sorry, I don't know what to do. This is okay. I think am I audible now?
Yes, ma'am.
Okay. Looks like sorry. So here in posterior urethral valve, the bladder is palpable because there is a valve at the posterior urethra, and this valve, once the baby passes urine from the bladder towards the urethra, it's like a shell, like we get the if we put a tube from below, it will cause a it will go. But if you child passes urine from above, the valves will get closed. So there is a severe bladder outlet obstruction, and with this obstruction, what we get is, sorry, I'll show like this only for a while, for
Okay.
2-3 slides. So here the child presents with the abdominal distension, hard football like cricket ball like hard bladder, and kidneys, bilateral hydronephrosis, hydroureter. There is a urosepsis and acid base disturbances and renal failure also many times. So what investigations we do is we do the ultrasound, MCU, and biochemical investigations. Urodynamics is a late thing for the further management. So MCU will have a elongated posterior urethra and U-shaped cutoff at membranous urethra, prominent bladder neck, and the valves can be seen as a lucencies and thick wall bladder with a VUR. So this is how, this is a trabeculated bladder with many trabeculations. This is dilated bladder neck. This is posterior urethra dilated, and this is closed at the membrane. So this is how, and obviously ultrasound will show us a trabeculated bladder, bilateral hydronephrosis, hydroureter, and dilated posterior urethra on the these are the findings. If the baby is okay, we do the primary fulguration of the valves at 5 and 7 o'clock position. And if the baby is having a hydronephrosis, severe hydronephrosis, renal functions are deranged, and like creat is very high and urea high, electrolyte imbalance, we put a feeding tube and or a Foley's catheter and let the creat come down, and once that comes down we do fulguration. Now as antenatal scan is quite common, we get the okay, fine. Very difficult.
आणि ते खालून फुल स्क्रीन कराल सगळ्यात खाली जी येते आहे
Okay.
68% लिहिलं त्याच्या बाजूला तिथून फुल स्क्रीन करा. येस. त्यानंतर नेक्स्ट करत जा.
नहीं वो नहीं दिखेगा सर.
मॅडम हे 68 च्या बाजूला जे आहे ना इथून फुल स्क्रीन करून घ्या.
हाँ ओके फाइन. या
तिथून फुल स्क्रीन करा आणि फुल स्क्रीन झाल्यानंतर त्याच्या अलीकडे जे 100% लिहिलंय त्याच्या अलीकडे मायनस प्लस कडे नाही त्याच्या अलीकडे लेफ्टला हाँ ते दाबा.
ये वाला.
वो फुल स्क्रीन आ जाएगा.
चलो,
उसके बाद में सिर्फ जो नेक्स्ट का बटन दबाते जाइए तो नेक्स्ट आती रहेगी.
Thank you, sir. So, antenatally, if you see a hydronephrosis, we do postnatal ultrasound on after 48 hours. If the child is very sick, we do it earlier. PUJ obstruction, if it is unilateral or bilateral. Bilateral is mostly because of the posterior urethral valve. And here we have already discussed about the posterior urethral valve. If it is a unilateral, we do a diuretic renal scan, that is DTPA scan after 4 to 6 weeks. And non-operative management, if the function of the renal scan is more than 40%, that is split renal function, means every kidney has got a 50% function. If the one kidney has got a more than 40% function, we do the medical management or just wait and watch. If the function is less than 40%, now it is said that if it is less than 25%, direct surgery. If it is between 30 to 30% above, we wait. So this is the plan of management for antenatally diagnosed hydronephrosis. So and we also measure the anterior posterior diameter of the PUJ and then decide if it is a very high and the function is also low, then we do the surgery. If it is less than 8 millimeter anterior posterior diameter, 8 to 12 is moderate and more than 12 is severe. So, but always the renal scan is taken into consideration. If the renal scans are not available, we go for IVP, but that is very crude. Now, meningomyelocele and meningoceles, these are also quite common. Here we diagnose antenatally, and if the child has got a other anomalies and bad lesion and associated with the hydrocephalus, many of them they terminate. And here what we see is a meningocele because the meninges are not there. So this is a meningocele, only the fluid is there. If the meninges they go in the sac, it is called as a meningomyelocele. So this is the difference between meningocele and meningomyelocele. So they are associated with the swelling, neonates present with the swelling on the back. It can be anywhere from here to here along the spine. And the surgery is done only if the child has got a small lesion, there is no bladder bowel involvement and the legs are normal. Sometimes this patient, they will have a bladder bowel involvement, means if we operate these cases, they will be wheelchair bound. So better to counsel the parents, and then for the next child go for add folic acid before pregnancy itself or before they plan the pregnancy. So they are associated with the back swelling, enlarged head, associated hydrocephalus, and lower limbs there is a talipus equinovarus, and bladder bowel involvement can be there depending upon the severity of the meningomyelocele, mostly associated with the meningomyelocele, not with the meningocele. So this is an antenatal scan which will show the meningomyelocele. So this is the now last slide, I suppose. Hydrocephalus. These are quite severe hydrocephalus. This is almost, you can't do much in these cases because the cortex will be paper thin. And for the moderate hydrocephalus and the child is better, in those cases, we go for the shunt surgery. Like VP shunt is put from making a burr hole in the scalp, and in the anterior horn of the lateral ventricle, the shunt is put, and it will be the lower end is put into the abdomen, and the mother or parent mother will pump the pump behind the ear lobe over the scalp bone, and a little by little fluid will be released in the abdomen. And to our surprise, these children, they do very well if it is done within time. And quite intelligent children, I have seen many of them, they're quite intelligent. There is no brain damage if done earlier. So thank you very much. I'm sorry I was not visible. Now
It's okay,
if
madam.
yeah, if you can make me host on the can disable the computer, and then you will be able to see me. Okay, thank you very much. If any questions are welcome.
Thank you, ma'am. आपकी आवाज ही बहुत मधुर
अरे
थी,
बाप
madam.
रे.
And such a nice lecture, and you have summarized in a very good manner the pediatric surgical problems. Now I hand over the mic to the other co-chairperson, Dr. Pratibha Kale, ma'am. Dr. Pratibha, over to you.
Yes, sir. Good evening, everybody. Now, I think it is the last session, a wonderful session for this today's CME, organized under leadership of President Dr. Naresh, Secretary Dr. Sushil, and with able guidance of Dr. Satish Agrawal, sir, Pandit sir. Now, moving toward the today's panel discussion, the topic is how to improve neonatal outcome. Very good topic. And for panel discussion, the moderator, today's moderator, the enthusiastic academician and the good orator, eminent pediatrician, Dr. Sandeep Dankhede. He needs, I think, no introduction, but just a formal introduction I'm giving. He was organizing secretary, Mahapedicon 2019. He was secretary IMA Amravati 21-22, and he is now vice president IMA Amravati branch 22-23. He was state executive member Maharashtra IIP 2018, 20 and 21. Was president IIP Amravati 2017. Everybody knows his tenure, and he's a faculty and unit head of Department of Pediatric and Neonatology, Institution of PG, Amravati. He is a director of Hope and Matruchai Hospital, Amravati. He is executive consultant at Parizat Hospital, also Amravati, and he was a faculty for NRP, NSSK, IMNCI, Hope and EPIC. And he was he was a joint organizing secretary, Mahapedicon 2005. And he was a chief bulletin editor, Maharashtra IP 2020 and 21. He was a sport coordinator of West Zone Pedivic 2020. With such a introduction, just I welcome today's moderator, Dr. Sandeep Dankhede, and all the panelists for the today's panel discussion. I hand over to Dr. Sandeep.
Thank you, Dr. Pratibha Madam. I must say I am a proud batchmate of Dr. Pratibha Madam, and we must congratulate Dr. Pratibha for becoming professor of Department of Pediatrics. So we get to begin with.
Wow,
Prakash,
congrats.
allow me the screen share, please.
Yes, sir.
Yeah. At the outset, I am thankful to IIP Amravati, Dr. Naresh, Dr. Sushil, and Dr. Ruturaj, and the whole team of IIP Amravati for giving an opportunity to conduct this very important panel discussion. I'm thankful to Dr. Satish Agrawal, sir, who is the convener of this CME and a brain behind this CME, who has arranged such a wonderful CME to improve the neonatal outcome. So thank you, Dr. Satish, sir. So, share. ठीक है अजून काही करायचं का म्यूट नाही ना ठीक है नहीं वीडियो ऑन है ठीक है okay is the screen visible?
Yes.
Okay.
Yes, sir.
Yes, okay, thank you. So first of all, let me introduce our today's renowned panelist. Dr. Sumedha Pandrikar madam is a senior gynecologist at Amravati. She is a member and past president of Amravati OBGY Society. Welcome, Dr. Sumedha ma'am. We have Dr. Sheetal Potode ma'am. She is MBBS MD OBGY. She is a consultant gynecologist at Sri Amba Multispeciality Hospital and Research Center at Amravati, a young and dynamic obstetrician and doing all kind of advanced obstetric work in Amravati. Our next panelist is Dr. Ninad Chaudhary, who is MBBS DCH DNB pediatric and has done his fellowship in neonatology. He's a consultant neonatologist and pediatrician. He's working as assistant professor at Department of Pediatrics at Dr. PDMMC Medical College and Hospital. He is also consultant at Hope Critical Care Hospital as well as Dr. Hedgewar Hospital and Research Center. He is working in neonatology and pediatric field from last 8 to 10 years. He is a faculty of basic NRP program, faculty at Mahapedicon 2019. He has conducted more than 10 basic NRP programs all over the Maharashtra. And he has an original research article on the bedside. 2D echo in the late onset neonatal sepsis. So with this brief introduction, let's move to our panel discussion. As we all know, the neonatology and newborn care is one of the most evolving field of medicine. And neonatal mortality rate in India for last year was 20.3. And as Dr. Taide madam has told that we have a target of bringing it down to the single digit, that is below 10 by 2013. We all know that India is a developing country and most of the pediatricians and obstetricians, they are working in limited resources conditions. We have not only limitations of the setup, we have limitations of technology, instruments, and even human resources. And that's why we are really trying to give our best efforts, best services to our patients. And I must say that all the obstetricians and pediatricians, they are carrying the responsibilities of more than one person in their setup and in their respective hospitals. So in this attempt, it becomes very important to update about the recent advances and guidelines in our field and to improve the interspecialty communication and coordination so that we can bring the better outcome in our patients, that is neonates. So here is the concept of mother and child hospital to improve the outcome of mother as well as neonate. Today, we will revisit various factors that can help to improve the neonatal outcome. We will also discuss the practical difficulties and potential or probable solutions. Viewers can send their questions in the chat box. We have gone through many theoretical things. We have heard of wonderful lectures today. We come across lots of theory also and lots of academics also. Now in this particular panel discussions, we are trying to know what exactly we are doing and what small problems, what practical difficulties we are getting and how can we improve them and improve the neonatal outcome. So here I come with our first question for Dr. Ninad. Dr. Ninad, you are also working in PDMMC and also doing calls at private setups. So what are the most important things that can help to improve the neonatal outcome?
Okay. Well, good evening, everybody. I think most important thing that help the neonatal outcome is first the teamwork. That is the obstetrician and pediatricians teamwork. We can hello, can I audible? Hello, sir, you are muted. Yeah. So first is a teamwork. That is, the obstetrician and pediatrician should work in the coherence. If there is any high risk delivery, you have to ask the pediatrician to come early. You have to inform the pediatrician early, so pediatrician can come with all the resuscitative equipments. He in advance can tell the NICU to keep everything prepared. And second is obstetrician and pediatrician in advance can counsel the parents. So this baby may need NICU. So there is a less stress for the parents also and for the clinicians also. Second most important thing to improve the neonatal outcome is the presence of skilled birth resuscitator, which is already told by Dr. Ramakant Patil sir, that at least one pediatrician trained in neonatal resuscitation must physically available at the time of delivery, every delivery, irrespective of the risk factor. It's high risk factor or low risk delivery, either it is vaginal or cesarean section. Third important point is timely management. Hit hard and hit fast. If you think the patient is in very much in risk or any other problems, so start doing things fast, or you just call the pediatrician. Third important thing is keep the all resuscitative or the cardiopulmonary emergency tray ready with you. So I think these are the most important factors which decrease the neonatal morbidity or mortality at the time of delivery.
Hello.
Sir,
Yes.
next slide.
Yeah.
So advanced preparation, second preparation of management of hypothermia, hypoglycemia and infection, availability of resuscitation kit, and the essential newborn care, which is all we already discussed in Ramakant Patil sir's lecture. So I'm not going in the depth of these cases. So as sir say, these three main causes of neonatal death we have to cover in this panel discussion, that is which can improve the neonatal outcome. First, we have to decrease the we have to prepare for the preterm birth, like antenatal steroid, preterm labor management. This will cover by our obstetrician colleagues. Then the birth complication, we have to avoid the birth complication by skill attendance and the good obstetric care. And third is neonatal infection. So prevention and essential newborn care, neonatal infection, breastfeeding, kangaroo mother care, all these three. So these 3 points are important.
Yes. Thank you, Dr. Ninad. As Dr. Ninad has said, it is really important to have a good teamwork as well as presence of the birth attendant, and we must do everything as a timely management. So thank you, Dr. Ninad. Those were the really important points to improve the neonatal outcome. And that's why about 71% of the newborn deaths are preventable and actionable now without intensive care. So we can prevent that 71% of neonatal death if we do proper perinatal care. So thank you, Dr. Ninad. So my next question is for Dr. Sheetal ma'am. How do you anticipate the fetus at risk? Because as we know, the care of the baby, a good outcome of the baby starts right from the mother's womb, and all the obstetrician, I mean the pregnancy itself is with the aim of having a healthy baby. And so we start caring from the mother's womb itself. So how do you anticipate the fetus at a risk?
Yes, absolutely right, sir. Anticipation of the mother is the anticipation of the high risk fetuses in antenatally is a great part on the part of the obstetricians. We must anticipate the fetuses which are at high risk, because as Ninad sir said, we have to tell pediatrician these babies are at high risk. So pediatrician should be ready to handle and tackle all these high risk babies beforehand only. So there are many conditions which are in the mother which lead to the fetuses at high risk. For example, if the mother is of advanced age, so she is prone to have preeclampsia or gestational diabetes mellitus. Also in advanced maternal age, the fetus may have more chances like Down's syndrome. So we have to prepare in all these patients. The list is innumerable. Like if the patient is obese, so the fetus is at high risk of IUGR, low birth weight. Also the mother if having gestational diabetes, so again fetus is prone more if the patient is on anti-diabetic drugs or insulin. So fetus may have hypoglycemia post delivery. So all these things you must know. Sir, Rh negative mother, if the mother is having anemia, mother with other medical disorders like hypo or hyperthyroidism, epilepsy, psychiatric disorder, if mother has kidney diseases, even small diseases like all infections, sexually transmitted diseases, HIV, HBsAg, TORCH group of infection, these expose the fetus to the high risk. Also, genetic abnormality. If the mother and father has consanguineous marriage, in these cases also fetus is at high risk, and obstetricians should anticipate it and screen it accordingly. Multiple pregnancies like twin pregnancy, these have a high risk of preterm deliveries, also of IUGR, and the mother with twin pregnancy has more chances of GDM and preeclampsia also. So in all, everything, all these high risk pregnancies, sickle cell, thalassemia minor, placenta previa, are prone for the for fetus for the high risk. Also, the sums generally when we diagnose major congenital anomalies before second trimester, we can terminate. There is an option of termination, but some anomalies are detected late, like hydronephrosis, hydrocephalus, multicystic polycystic kidney diseases, and as Usha ma'am has nicely elaborated, all other congenital anomalies. So these are very high risk, and we have to anticipate these fetuses previously.
I think very well explained, Dr. Sheetal ma'am. Most of the times patient has only one concern, ki cesarean honar, ki normal delivery honar. But our obstetric colleague has to look for so many things. They have to screen for so many things, and so as to carry the pregnancy in a normal manner. So thank you, Dr. Sheetal ma'am. You have really explained very well how you anticipate the fetus at risk. So my next question is for Dr. Sumedha Pandrikar ma'am. Ma'am, how do you assess the fetal well-being?
Thank you, Sandeep. I am audible?
Yeah, ma'am.
Yes.
Thank you, Sandeep. At the outset, I must thank Dr. Satish Agrawal sir, Dr. Naresh Tade sir, Dr. Sushil, and Sandeep yourself for giving me this opportunity on this IIP platform. Thank you, Sandeep. The aim of this fetal well-being assessment is first to avoid fetal deaths and to ensure the satisfactory growth and well-being of the mother. Second main aim is to recognize the fetus at risk. There are increased chances of fetal deaths at the late third trimester. So here we concentrate the assessment of fetal well-being in last trimester only. This assessment is divided into two types. One clinical and second is the biophysical. In clinical, there are so many the methods. That is the monthly weight gain of the mother, her BP, her blood pressure measurements, her fundal height, her size of the uterus, and per abdominally palpable amount of the liquor. These are comes under the clinical methods. Next comes the biophysical. There are some tests which includes this fetal well-being under the title of this biophysical profile. This test includes daily fetal movement count, cardiotocography, non-stress test, biophysical profile, sonography with color Doppler, the fibroacoustic stimulation test, and last but not least is the contraction stimulation test or oxytocin challenge test. First, we will see about the daily fetal movement count. It is said that the daily 10 count per 24 hours we should take this for ideal movements. The fetus who does not require this ideal nutrition, who does not get this ideal nutrition from mother, or these fetuses have defective maternal fetal circulations, have decreased movements. But this method is a crude method, gross method. Loss of movements, complete loss of movements, commonly followed by stoppage of the heart or disappearance of the heart within next 24 hours. So, if daily fetal movement count are less, the patient is subjected to non-stress test. For What is this non-stress test? It is a continuous electronic monitoring of fetal heart rate along with the recording of the fetal movements. This acceleration of the heart rate, fetal heart rate during the fetal movement indicates a healthy fetus. Reactive NST means there are two or more accelerations or uh, 15 beats per minute, and this acceleration should remain for 15 seconds. So this is the reactive NST. What is the non-reactive NST? There is an absence of any fetal movements or any fetal acceleration. This suggests the fetal hypoxia. A baseline variability of 5 to 25 beats per minute is a sign of the good fetal well-being, or it is a sign of a healthy fetus. Second is the contraction stresses, but nowadays it is not done because there is a always hidden fear of that a patient may go or land up in a preterm labor. Then comes the fibroacoustic stimulation test. It is one of the theoretical tests. No one should do this test. A specially designed stimulator is vibrated and kept near the mother's abdomen, and fetal accelerations are counted, or they are counted on a graph, and the acceleration and deceleration of the fetal heart rate are noted. These are the comes under the biophysical test. Next comes the biophysical profile. In biophysical profile, there are 5 points. These should be taken into consideration. First is the fetal heart rate. Second is the fetal respiratory movements. Third is the fetal body movements. Fourth is the fetal muscle tone, and fifth is the amniotic fluid liquor or amniotic fluid index. Each one of these 5 points have score of 2, and score from 2 to 10 is there. If score is 8 to 10, it suggests healthy fetus. If score is 6 to 8, then the fetus is having decreased feto-maternal circulation, or decreased placental insufficiency is there. This should be considered as a necessity for delivery of the fetus. If the score is 8 to 10, then there is no fetal hypoxia. Score 6, chronic hypoxia. Score 6 to 4, 4 to 6 is a suggestive of chronic hypoxia. So obstetrician must think about the delivery of a fetus immediately. Nowadays there is one more modern assessment is there. It is called as the modified biophysical profile. What is this? The biophysical profile, including non-stress test, means modified biophysical profiles. Healthy fetus have reactive NST and AFI, or amniotic fluid indexes, more than 5 centimeters. Non-reactive NST or amniotic fluid index less than 5 suggest abnormal biophysical profiles, or fetus in jeopardy, and he should be delivered as soon as possible. Then next comes the sonography with color Doppler. As if we all know the indication, advantage, and uses of the sonography machines to develop the to discover the complications of the pregnancy, and to know the fetal anomalies. Color Doppler of the uterine, middle cerebral artery, and umbilical artery should be done, and it suggests the uteroplacental insufficiency. So it should be suggested that this color Doppler along with sonography should always be done to assess the fetal well-being, or to assess the fetal at risk.
Okay, thank you, madam. It was really a wonderful explanation of the how you assess the fetal well-being. I must say that it is not only the neonatologists who take care of the babies. It is actually the obstetrician who is taking care of the babies right in the mother's womb. So thank you for that detailed explanation. I think we are also really not aware how thorough and how detailed assessment need to be done for the fetus in the mother's womb. So that was really a wonderful explanation. So my next question is for Dr. Ninad. Ninath, what are the things which were in practice previously but should be avoided immediately after the delivery? The aim of asking this question, I will tell after the answer of this question. So, Dr. Ninath, can you please elaborate?
Yeah. Initially, when in the previous era, after delivery of the baby, if the baby is not breathing or if the baby is not crying, then there are various crude methods was following. That is slapping the baby on the back, holding the baby upside down, rubbing the back vigorously, or putting the finger in the anus. These are all crude methods. People are using somehow at home or at hospitals, and currently 90% people are not using this method, but few people or few colleagues still very much fond of holding the baby upside down, rubbing the back vigorously. But these are all very detrimental practices. Even if the baby is not crying or not able to breathe, you have to follow simple basic NRP guidelines. Only ambu bag or gentle rubbing or gentle stimulation. These are the immediately after birth. There are some people also sprinkle the waters. It causes the vasovagal reflux. Baby goes into the bradycardia. So these things are immediately after the birth. We have to avoid. Some other things we have to avoid is the giving about breastfeeding. Some people avoid the breastfeeding immediately after birth and start giving the pre-lacteal feeds such as sugar water, then honey. So we have to avoid this also. As the promoter of the breast milk bank and the breastfeeding, we have to always follow the breastfeeding protocols. And next immediate important thing is immediate clamping of the cord. These are the very important topic we will discuss afterwards. Already Ramakant Patil sir discussed this, but I think I have to give the message. We have to stop this practice of immediate clamping of the cord. We have to go for the delayed clamping of the cord. Okay. So this is the important thing I think we have to avoid after delivery of the baby.
Yes, very well said, Dr. Ninath. I remember about 25 years back during our internship, we have witnessed all these things being done at PSC level. But nowadays, nobody is doing that. But yes, this is one thing which we still see, that most of the obstetricians are still immediately clamping the cord. And I think this is something which we all, most of the studies have shown that we can really try or de-learn these things to learn that it should be clamped after 1 to 3 minutes. So this is the one thing, I think the clear message for showing all these things, that anybody will say, no, nobody does this, all these things. But this one thing, that is immediately clamping of the cord, is still practiced in obstetrics. So I think this is the message that we all should try to go for the delayed clamping of the cord. Okay, thank you, Dr. Ninath.
Thank
you. Yes, our next question is for Dr. Sheetal ma'am. Sheetal ma'am, what are the antenatal interventions to improve the neonatal outcome?
Yes, sir. Before giving answer of this question, I would like to comment. Actually, previously, many of gynecologists fond of doing early cord clamping, but also now Laksha Foxy and Laksha Manyata, they all have changed these protocols, and active management of third stage of labor, they have erased the sentence of early cord clamping and they have done it is delayed cord clamping. And they have done also studies, delayed cord, previously studies were there ki, delayed cord clamping may cause PPH. But against that, the studies are coming ki delayed cord clamping does not alter, does not cause PPH. So nowadays, maximum obstetricians are trying to late cord clamping and then keeping the baby on the abdomen of the baby, so the kangaroo mother care can be received, and also early breastfeeding.
Thank you.
What are the there are many antenatal interventions to improve the neonatal outcome. Basically, it depends on different conditions. So if you want to prevent the neural tube defect, folic acid supplementation prenatally, even 3 months before the pregnancy, we should advise folic acid supplementation. Anemia causes many hazards in baby. So iron, folic acid supplementation and calcium supplementation in pregnancy are the basic interventions which should be done in the antenatal period. Routinely, we do all the investigations like blood group and RH typing. So we can know the RH negative mother status and work accordingly. If mother is RH negative, then indirect Coombs test is done from the first trimester at every 4 weeks. So to detect any RH isoimmunization. And in the RH negative mother, anti-D is given at the 28 weeks of gestation if ICT is negative, and to prevent RH isoimmunization. And after delivery also, we give anti-D. So all the basic investigation like CBC, HIV, HBsAg, thyroid, urine routine, blood sugar, all these are advised in antenatal mother. And the most important thing, previously we were not doing, but nowadays everyone is doing HB electrophoresis is the must in each and every pregnant woman, because it detects even a thalassemia minor or sickle cell trait. So by knowing if the pregnant patient is thalassemia minor or sickle minor, then HB electrophoresis is also advised to the father to detect whether if the both parents are thalassemia minor, then we can advise amniocentesis to detect early if the thalassemia baby of thalassemia major or sickle cell major. Also, we do all the prenatal testing. I will discuss it further, like the double marker and quadruple test. While routine antenatal checkup, we detect short cervix, or on ultrasonography, we detect the short cervix or the if history of preterm labor. Then we can suspect the preterm labor and work accordingly. If the patient is having threatened preterm labor pains, so we try to give tocolytics just for 24 to 48 hours, just to give the fetal lung maturity, to time to for the fetus to get fetal lung and heart maturity. We give injection betamethasone or dexamethasone for it. And if the fetus is below 33 weeks, also injection magnesium sulfate is given for neuroprotection. It is in the given in the loading dose 4 gram, and after that 1 gram per hour over 24 hours for the neuroprotection. Nowadays, it is even said, previously it is said that injection betamethasone is only given before 36 weeks. But some studies are saying if you are doing elective cesarean section before 39 weeks, in these cases, also they are advising injection betamethasone to for the lung maturity. These are the newer studies which are showing that. If we in antenatal checkup we found the fetus is having IUGR or oligohydramnios, then we do counseling of the parents about the diet and give protein supplementation, so we can prevent and early or late IUGR fetuses. Also, all the immunization like tetanus toxoid is very important in all patients, prevent the fetus of any diseases. And nowadays the practice is like second dose of TT, instead of giving TT we advise triple vaccine DPT, so that fetus can get advantages of
आवाज म्यूट झाला का मॅडम? हॅलो,
नेट कनेक्शनचा प्रॉब्लेम आहे.
हा, इंटरनेट कनेक्शन इनस्टेबल असेल. हॅलो,
पुढचं घेऊन घे.
हा, ठीक आहे. So that was really very well explained. we must say that it is not only the neonatologists or pediatricians who are treating the babies, but even obstetricians are treating and preventing the further comorbidities in the neonate, in the fetus. So thank you, Dr. Shidal Madam, for that explanation. Our next question is for Dr. Sumedha Madam. Sumedha Madam, how do you prepare for the delivery of neonate at risk? What are the special arrangements we need to do? We'll only restrict here to some specific arrangements. We'll not go in the detailed arrangements of the labor room, but some specific arrangements if the child is suspected to be high risk.
Thank you, Sandeep. As Ninad said that it should be always be a team approach of an obstetrician and neonatologist who is specially trained in neonatal resuscitation. Everything means all supplies and equipment should be necessary in the labor room for the complete resuscitation of a mother and her newborn baby. This all equipment should be readily available, and this is the most important, that they must be functional at the birth of the every neonate. So some important things are that every obstetrician or neonatologist must know the location of all this equipment inside the labor room, and know how to call if any further help is required, or who is available if further help is required in that delivery room. Secondly, we should use the available information regarding the perinatal or intrapartum history of any maternal diseases, or any maternal medications, or any medical disorders, or any other risk factors. We should anticipate or plan about risk factor associated with delivery of a neonate or neonate in a high-risk mother, like hypothyroidism or Rh negative, or pregnancy-induced hypertension, or mother associated with diabetes mellitus. Communications and explanation of associated risk should be done. The risk factors should be explained to the relatives and patient herself. The sequences of or consequences of this risk factor should be explained to her relatives and patient herself. Documentations of all the everything should be done, and it must be done in view of the Consumer Protection Act, or in view of medical legal purposes if it required in future. So tertiary care facilities should be ready for high-risk mother and her neonate beforehand at right time if it required. This preparation should be done for the delivery of a neonate.
Sandeep sir, you are muted.
Yes, that was very well explained, Dr. Sumedha ma'am. All the precautions for the at-risk neonate. One more thing I would like to add over here is it's better if we could counsel the relatives that this high-risk neonate may require hospitalization at NICU. If we counsel that in advance, probably it can save our time later on after the delivery of the baby, where relatives are probably not ready for prepared for the transfer of the baby also, or take the decision where to shift that baby. So that is one more thing we can do. So that was really very well explained, ma'am. So
yes,
thank you.
The anticipation and planning of the risk factor.
Yes. Okay. Yeah. Right.
Sorry, my network was gone. Sorry.
Okay. Yes, but now you are joined. So that was a wonderful explanation, ma'am. To Shital ma'am. So our next question is for Dr. Ninad. Dr. Ninad, we recently discussed about cord clamping, delayed cord clamping.
Yes.
So what are the benefits of that delayed cord clamping for the baby?
Yeah. See why we are emphasizing on the delayed cord clamping repeatedly, because as previously we said, there is a early cord clamping was done, but now very Cochrane reviews, various meta-analysis, various research work shows the delayed cord clamping are it's very beneficial for the neonates, not for the immediate outcome, but for the later in the life also. Why? Two things. It improves the transitional circulation and the blood volume. It decreases the chances of NAC and IVH in immediate neonatal period, and in the later age group, it improve the hematological status of the child. It reduces the anemia, which is the most common under 5 cause of mortality, anemia, diarrhea. So for reduction of anemia and prevention of anemia, in the neonatal age group only, we have to do the practice of delayed cord clamping, and it also increases the iron store.
Yes.
So, definition of delayed cord clamping, I think we already discussed. It is the clamping of the cord at the 1 to 3 minutes, or simply cessation of the pulsation of the cords. So you wait for at least 1 minute. You can wait up to 2 to 3 minutes, which is more beneficial.
Yes, that's very well said, Dr. Ninath. Even Dr. Patil sir has also explained in this talk, and he has emphasized the importance of delayed cord clamping.
It is actually very cost-effective measure to reduce the anemia in the neonate and in children also.
Yes, but is there any contraindication for delayed cord clamping?
Very few contraindication, some misconceptions. First contraindication is baby who need the immediate resuscitation. Baby would not cry. Baby need active resuscitation. Second is baby with RH incompatibility. We try to avoid the delayed cord clamping. On obstetrics part view, there is if the placental circulation is not intact, like abruption, placenta previa, or umbilical cord avulsion, we avoid the delayed cord clamping. Previously, there is misconception that delayed cord clamping may cause the hyperbilirubinemia. It increases the risk of polycythemia. But Cochrane analysis and meta-analysis and research shows the chances of hyperbilirubinemia is very less. And if you take the hyperbilirubinemia and the anemia side by side, then the treatment of hyperbilirubinemia is very cost effective, only phototherapy, and it is very less. But anemia, it takes the more hazardous side effect on the baby. So there is no, I think there is no doubt about delayed cord clamping.
Yes, so point very well taken, Dr. Ninath, that apart from these few contraindications, one should go for the delayed cord clamping.
Delayed cord clamping, yes.
Yes. So my next question is to Dr. Sheetal ma'am. Sheetal ma'am, how important is the assessment of gestational age of the fetus?
Yes, just assessment of gestational age of the fetus is very important, because the cases, if the like whether the patient is preterm or postterm, this main decision is should be taken only by if you are knowing the gestational age of the fetus. Also, the mother with having preeclampsia or any high risk pregnancy in which we have to terminate early for the sake of mother. But if we know the gestational age of the fetus, then we can prepare ourselves and give what I have talked previously, injection betamethasone and Maxel for the fetuses. Also, the fetus in the gestational diabetes, and all these cases, the gestational age assessment is very important. And how it is done? Simply, it is we all know it is by last menstrual period. If the patient is having regular menstruation, but if patient is not having regular menstruation, or if she is not knowing her LMP, last menstrual date, then the perfect assessment is by first trimester ultrasonography. It is only done with first trimester ultrasonography, preferably before 8 weeks of gestation, which is plus minus 1 or 2 days only. But if we will assess the gestational age by second trimester and third trimester ultrasonography, the error of judgment is more of 1, 2 weeks or 3 weeks. So only first trimester ultrasonography is for the assessment of gestational age to for everything, to time of termination of the pregnancy, for preterm, postterm, and all these things.
Yes, that's very well explained, ma'am. Because even in the neonate also, for taking various decisions, we must know the proper gestational age of the babies. Even for the retinopathy of prematurity screening, we have a different guidelines whether to do it at 15 days or 21 days or 28 days accordingly. So thank you very
I want
much.
to add the same. I want to add the same point.
Yeah.
For the retinopathy of prematurity, gestational age is important.
Correct.
If he is very much premature, we can do at 15 days only. 15 days, 21 days, as you already said.
Right.
So only that point we have to add.
Correct. Yes. Next point is for Sumedha ma'am. Sumedha ma'am, many a times we have a very high risk delivery, and we know there is extreme prematurity, or there may be a twins or so. So in such cases, how important is the selection of place of delivery and in utero transfer?
Thank you, Sandeep. Selection of place of delivery, that is a birth unit. We all know there are the standard labor room protocols are there. So every labor room should obey these protocols and complete or fulfills all these protocols. This labor room should be standardized. It provides all the support for resuscitation of the mother and her newborn. It should provide privacy and comfort to the labor patients. It should be catering to all mothers during labor and immediate postpartum period. In utero transfer means transferring a baby while they are still in utero. In high-risk mother who are giving birth to if they are gives birth in a specialized unit, there will be an immediate assess with right equipment and right expertise. So the neonatal or the perinatal outcome should improve. Extreme preterm baby, there is extreme preterm baby likely to be born. So the baby is transferred in utero to the tertiary care. These are the some advantage of in utero transfer. But there are some other indications for in utero transfer also. These are the lack of the staff, or the staff is not available, or bed is not available, or ventilator is not available, or your staff is not enough trained for neonatal resuscitation or neonatal care. So in that case also, you can shift the baby in utero. Yes, these are the advantage, but some disadvantage are there, like there is a burden on health system, or there is a financial and emotional burden to patients of being away from the home.
Yes, that is really a very important thing you have explained, ma'am. So I think it has a medical legal importance also. Many times, if you have some limitations, it is better to shift that patient at the place where he or she will get the proper care. So thank you, madam. Thank you for emphasizing the importance of in utero transfer and selection of the place of the delivery. Dr. Nidan, can you suggest a program of further monitoring of baby in a very short? What important things we should monitor in a period? We are a little bit lacking in time, so we will try to move a little bit faster.
Yes. I think all of us know how to monitor the baby in PNC, but I suggest some few points. First, initial 24-hour is very important after delivery. We have to monitor the vitals like heart rate, respiration, temperature of the baby, either baby's cyanosis, pink or yellow, because in RH incompatibility, sometimes jaundice starts within 24 hours. Then urine and stool frequency. 24 hours urine, one urine and stool frequency in 48 hours. Then activity of baby. Is the baby active, lethargy or irritable? Then blood sugar monitoring in the high risk babies, such as baby less than 2 kg or babies more than 4 kg. I really emphasize on the blood sugar monitoring. It is very cost effective way to monitor the well-being of the baby. If the baby's sugar is less, you can take the swift action and you can avoid the hypoglycemia and further brain injury to the babies. And it is very well available in all labor units or all delivery units. Then second important thing is breastfeeding evaluation. How baby is taking breastfeed, he is taking well or not. If there is any problem, you can call the pediatrician. And if very important point is any damn maternal concern regarding baby. माझा बेबी दूध पीत नाही आहे, माझा बेबी थोडा सुस्त वाटत आहे, माझा बेबीला काही प्रॉब्लेम वाटत आहे. Actually, sometimes in our hurry, we ignore the maternal concern about the baby, but later on, these points sometimes hound us.
Right.
Yeah. So I think this pro forma is very basic
Yes,
pro
so
forma.
this is very important to monitor the baby in the PNC and early pickup of the conditions if at all
Yes.
there is any morbidity. So thank
Yes.
you, Dr. Ninad. Actually, the topic of prenatal diagnosis has been already covered in detail by Dr. Murke madam. But Dr. Sheetal madam, can you enumerate a few modalities of prenatal diagnosis and their recent advances in short?
Yes, actually, Jagruti ma'am has already very well explained it. But just to enumerate, at 11 to 13 weeks, we do double marker and along first NT scan and so of ultrasonography of these babies. And at the same time, we also advise PI to predict any preeclampsia or IUGR in these babies. Along with NT scan, we do double marker in 11 to 13 weeks of the pregnancy. If this gestation is missed, then triple marker or quadruple markers are the options, but quadruple test is more superior than triple marker. Nowadays, triple marker is not doing by any gynecologist, but all these have the sensitivity, less sensitivity of around 93 to 94%. So for medical legal purposes, the NIPT is now more advanced, which is non-invasive with 99% accuracy, sensitivity and specificity, which we may advise. And if all these tests, double marker, quadruple or NIPTs of suggestive of high risk, then we advise amniocentesis or chorionic venous biopsy sampling for any chromosomal analysis, genetic testing, and this is done by PCR or fish testing. Also, as I told you before, if mother and father both are thalassemia or sickle cell minor, then also we advise amniocentesis in these babies.
Yes, thank you, Sheetal madam, for briefly enumerating the conditions which are important for prenatal diagnosis. So my next question is for Dr. Sumedha madam. Madam, can you briefly mention what are the various maternal conditions that affect the fetus?
Yes, there are so many antepartum maternal medical disorders like thyroid disorders, anemia, pregnancy-induced hypertension, diabetes mellitus, some cardiac diseases, asthma, infective conditions like hepatitis, herpes, rubella, tuberculosis, malaria, and now one more added COVID-19. This infection during pregnancy affects the perinatal outcome of that neonate. Some intrapartum risk factors that are more important for this perinatal outcome. These intrapartum factors are emergency LACS, forceps or any assisted vaginal delivery, abnormal presentations, maternal general anesthesia, or any medications like Maxal, placental abruption, polyhydramnios or oligohydramnios, IUGR, fetal microsomia, shoulder dystocia, intrapartum vaginal bleeding, meconium stained amniotic fluid or liquor, and prolapse umbilical cord presentation. These are the some intrapartum factors that affects the adverse that may cause the adverse outcome of that newborn baby.
Yes, thank you, Sumedha madam. You are really well explained all the maternal conditions that can affect the fetus. So we must be aware of these conditions. As you know, Dr. Ninad, there is many times there is some discriminatory conditions like borderline situations where on one hand we don't want to separate the baby from the mother, but at the same time we don't want that baby should face the life-threatening situation. So we are trying to standardize our neonatal practice and our admission protocols. So what are the indications for admission to SNCU? Can you briefly explain few?
Yes, there are few important indications such as the prematurity, that a baby born less than 34 weeks, even if his weight is more than 2 kg, sometimes weight is more, baby is LGA, but if he is premature less than 34, we must admit in the NICU at least for 48 to 72 hours so he can be stabilized. Then low birth weight baby less than 1.8 kg, large babies more than 4 kg, which are mostly turn out to be hypoglycemic sometimes. Then the perinatal asphyxia, baby requiring neonatal resuscitations. Then respiratory distress, neonatal jaundice, baby who is refusal to feed. That they already I said first 24 hours you have to monitor breastfeeding. If the baby is not able to feed, baby refuses to feed, then you have to take the baby in the NICU for monitoring. Then important thing is hypoglycemia. You have to monitor the blood sugar. And if baby is hypoglycemic, not able to take feed, then you have to shift the baby. Or any other condition where attending physician thinks baby need the NICU treatment. Anytime condition.
Yes.
You have to
Yes,
consent
this is
and you have to shift.
right.
These are the numerous conditions, around 24 conditions. These are very well given in the our Government of India protocol. These 14 conditions such as hypothermia, hyperthermia, distension, oliguria is sometimes we ignore the urine output, but it is very important. As already sir already said, it may turn into RTA patients. Patients in future turn into RTA or patient turn into a kidney damage. So all these, I think 24 conditions are important for the NICU admissions.
Yes, thank you, Dr. Ninad. Actually, the breastfeeding is one of the topic which the whole day CME can be on that. There are many practical difficulties in breastfeeding. So, in short, Sheetal ma'am, can you explain the practical difficulties? Do you insist on breastfeeding only, or shall we give any top feed?
No, actually, some of the main difficulties which we face in the day-to-day practice, that मॅडम बाळनं दूधच नाही पितंय, मॅडम हिलानं दूधच नाहीये, प्रत्येक आणि बेसिकली माझ्या म्हणण्यानुसार तर सायकोलॉजिकल हा सगळ्यात मेन प्रॅक्टिकल डिफिकल्टी आहे की जी आजूबाजूचे सगळे त्यांना असं वाटत असतं की पहिला दिवस आहे म्हटल्यावर तिला अगदी गाईसारखं धो 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 दूध आलं पाहिजे आणि ते पुरलं पाहिजे, पण तसं नसतं. मग त्यांना ते इतकं काउन्सिलिंग करावं लागतं की नाही, एक थेंब जरी आलं तरी सुद्धा त्याच्यात भरपूर एनर्जी असते की जे बाळाला पुरते, तर त्यांना ते काउन्सिलिंग खूप महत्वाचं आहे. आणि प्रायमरी ग्रॅव्हिडाज these patients have main problems in latching. So how to hold the baby, what is the correct position in breastfeeding. So in all these, counseling by doctor as well as paramedical workers is very important to tackle these problems.
Yes. Thank you. Yes.
Other medical problems are there, which we all know: sore nipple, cracked nipple, or engorgement of breast. These are other problems, but I think this is the main problem which we face in day-to-day practice.
And despite of all these problems, our ultimate recommendation is breastfeeding and breastfeeding only, and no prelactial feeds. So we all insist for that. Even Dr. Patil sir has also explained the importance of breastfeeding in preventing the neonatal morbidities.
Yeah, I want to add one
Yes.
point. Our chairperson, Dr. Pratibha Kale madam, is doing excellent work in the breastfeeding counseling.
Correct.
And breastfeeding management. So I think at the end of the panel discussion, she can add some points regarding breastfeeding, practical difficulties in breastfeeding management.
Yes, definitely. And even Human Milk Bank is really working very well at PDMMC hospital and all. So that's very well said, Dr. Ninad. Dr. Ninad, kindly suggest any pro forma for the notes to be written by the pediatrician attending a delivery or LSCS, because many times we see that chalta hai to sab chalta hai. So at many places there is no standardization. Just pediatrician has been called, they are just saying, "Ha, sagar theek hai," but that can put them in medical legal problems some or other time. Some sudden infant death or something occurs, and that time if you have a good paperwork, that probably help you. But then there are some problems which are been picked up later on. So what was the condition at the time of birth? If you really put it down on the paper and the proper notes are been put by pediatrician, that is always useful. So can you suggest any pro forma for the note?
Sir, I think I suggest a pro forma. Nowadays, various written pro formas, already well typed and well written pro formas, are available on the NNF site, obstetric sites. So all the gynecologists and delivery units can take that pro forma and keep in the baby's file as a printed. So we can have we can avoid the time. But I have to suggest some basic points such as the date of birth, time of birth, gender, and weight of the baby. Then the detailed general examination, head-to-toe examination, which hardly take 2 to 5 minutes. Then important point like umbilical cord, it is single umbilical artery or not. Then anal patency of the baby, cleft lip, cleft palate, and other anatomical anomalies such as CTV or some polydactyly or some ear anomalies and the spine anomalies. Next important thing is femoral pulses. We always document femoral pulses. Sometime in newborn babies after delivery, it is difficult to document femoral pulses, but keep sure that you have to document after baby stabilizes within 24 hours. Then two important points you have to write during in notes is mother blood group to see the jaundice or to see the ABO incompatibility or RH incompatibility, and the important maternal history, as Sheetal madam and Pandita madam said, some antepartum hemorrhage or some PIH or some RH problem or some other problem. So these are the basic notes we have to write after delivery. And as you suggest, as you said, in this medical legal era, we should write delivery notes after the for the babies, because we have to take 5 minutes and we have to write these notes to avoid the further trouble.
Yes, so the message is very clear that the proper note should be put. You can even have a printout pro formas and you just tick most of the things and write very few things, and it doesn't take much time. So the notes are very important point after attending a delivery.
There is no chalta hai in the delivery notes.
Correct.
You have to write down.
Yes, yes.
Even if you are the utmost busiest pediatrician.
Yes, that is a comment from one of the busiest. So we must follow the this suggestion from Dr. Ninath. So thank you, Dr. Ninath. We all know that the care, if we really want a good outcome of the baby, few important things like breastfeeding practice, very important thing. Human milk banking is there to help if the mother cannot feed for some or other reason, and there is something like kangaroo mother care. So I think we can see even this mother who is so happily she's and the babies are sleeping quietly, and she's giving kangaroo mother care as well. So such photographs are really encouraging. A few word about kangaroo mother care in short, Dr. Ninath.
I think it is kangaroo mother care is very much important, very cost effective. It is not only kangaroo mother care, it is kangaroo father care also. Yes. It is because in this picture that we see the mother, but in very much I think not in India, but also in some places in India and maximum in outside countries, parents, that is father, is also giving the kangaroo care. Kangaroo care is important for the preterm low birth weight babies, the babies who are not able to maintain their own temperature. Actually, KMC started in the South African countries, where they are not able to purchase the incubator. So they getting the ideas of that KMC, kangaroo. So important point in kangaroo mother care briefly I did. It helped to maintain the temperature. It helped to stabilize the respiration and the heart rate of the baby. Baby is mostly getting the warmth. Baby get encouragement for the breastfeeding. Physical stress, as Dr. Rushikesh said, that physical and mental stress of the babies decrease if the baby is in kangaroo mother care. Various meta-analysis and Cochrane review shows early stability of the heart rate, saturation, respiration, plus in future the neurodevelopment of the babies are very good in kangaroo mother care. Another important point is it is very cost effective intervention, which can, if you have I think if we have lack of incubators or lack of open warmer system, we can go with the kangaroo mother care. Only important thing is we have to do counseling and the preparation for the mother and the parents.
Yes, thank you, Dr. Ninath, for emphasizing such an important and cost-effective modality like kangaroo mother care. So
I have to emphasize one point. We can give the in all obstetrics unit or in NICU units, you can keep one large LCD and we can run the videotape of the kangaroo mother care videos. in our PDMMC step down unit, in the post neonatal units, we have one large LCD and continue videos are running for the mother and their relatives as a kangaroo mother care, breastfeeding videos, how to express milk, how to do kangaroo care, everything. So it will be very helpful.
Thank you, Dr. Nidat. Those who are the hospital owners, they know that there is a new Maharashtra Nursing Home Registration Act 2021. Are there any provisions that will help to improve the neonatal outcome?
Yes, definitely. New Maharashtra registration have very much new rules and regulation. As you see in this slide, we all maternity home, they have all obstetric part, they have well covered, but we see some maternity home, they lack of neonatal resuscitation kit. अरे सर आप आपका लेके आओ आने के वक्त, हमारे पास नहीं है. This is the situation in some place, not in all, but 5 to 10% places. So I think in this new Maharashtra Nursing Registration Act, they made it compulsory to keep neonatal resuscitation kit, to keep one minimum infant warmer. It is helpful in the winter period, or it is helpful in the baby who is hypothermic or low birth weight babies. Then all these other things, that is instrument required for cardiorespiratory resuscitation, emergency trays, firefighting equipment, these are all there. But important for a neonatal care, one resuscitation unit and infant warmer. And as you said, already seen, room for the infant warmer in maternity home. If they are available, you can keep the infant warmer in the rooms, or at least at the delivery point or in the OT. So baby can give the warmer. Warmth.
Okay, thank you for telling all those recent advances, Dr. Ninad. So at the end, there is, I think, with such a wonderful explanation by our eminent panelist, there is some take-home message which we will like to give to our all audiences. The teamwork and interdisciplinary communication amongst pediatrician and obstetrician plays an important role in preventing the neonatal morbidities and improving the neonatal outcome. Anticipation of high-risk neonate is of utmost importance. Timely intervention is crucial in improving the neonatal outcome. Timely referral, selection of delivery place, and in utero transfer should be given importance in due cases. Close monitoring in PNC ward and room is helpful to pick up the neonatal morbidities earlier. And breastfeeding and KMC are the most cost-effective interventions to improve the neonatal outcome. So with this, I thank all our panelists and hand over the mic to our chairpersons.
Thank you very much.
Thank you.
Thank you.
I am also thankful to Pediatric Association, Pratibha ma'am, Sandeep sir, and Satish Agrawal sir, that they have given us opportunity to talk in front of you. Thank you.
Okay, thank you. Thank you very much, Dr. Sandeep, for this excellent CME or excellent panel discussion. You have covered almost all the points related to newborn outcome. Definitely, and it was update, and it is update for everyone. Listen to it, and also thankful to panelists, Dr. Sumedha, Madam, Dr. Sheetal, Dr. Ninad. Yeah, everybody has taken care of every part of baby as mother as well as baby very nicely. Means it is a comprehensive care starting from antenatal to postnatal. Thank you very much. Dr. Ninad just asked about some tips about the breastfeeding. Just I will share. You have covered almost everything, and it required again separate one-day session. But the one thing you have to emphasize that the breast stimulus for breastfeeding secretion, Dr. Sheetal has already elaborated about that. That is definitely the counseling, and give confidence to the mother. But that you should tell them that the best stimulus is the sucking, and you can give the example of the your twins babies. If there is a triplet, if there is twin, you can feed the baby accordingly, because whatever flow will come, that will be replaced. If there is a single baby secretion, but if there is no baby, no secretion, the secretion will stop. You have to give that example. Second, the position of the breastfeeding. Almost 90% mothers feed the baby in a sitting position. I don't know, even in PDMMC also. But mother will get exhausted, and that is the again reason for having lose the confidence, having a backache and all that, and that will again have a lactational failure. That's why you have to demonstrate the proper position. Even in the lying down position, initially mother, all of you know that how much she is exhausted. So you can ask them to feed the baby in a lying down position. And the prolactin hormone, you have to tell about the prolactin hormone. It is not from the uterus or ovary. In the PDMMC, we are routinely following or doing that. Dr. Ninad knows the induced lactation. Recently, one mother is there in the college, and that mother, baby was 900 grams. Now baby is of 1.45, that is 1.5 kg. And induced mother lactation means that the mother who is adopted that is giving very much nicely feeding the babies, and secretions are there. And that's why you have to say that the prolactin will come from ultimately from the brain and not from the uterus. That you have to counsel. If you have a good or you have confidence, or what we say about the breastfeeding, then only the milk will come, otherwise it will not. These are the few things. Definitely everybody has covered very nicely and very fruitful to everybody, all the obstetrician, all the general practitioner, all the neonatologist and the pediatrician. Thank you very much.
Madam, I just want to add one point. Actually, you are telling about the position. पण मी आमच्या हॉस्पिटलमध्ये घडलेला एक एक्सपिरियन्स सांगते की काय होतं की जर तुम्ही सांगा पेशंटला की जर तुम्ही झोपून पाजलं तर त्या टेकन फॉर ग्रँटेड घेऊ शकतात पुढे जाऊन. आणि मग असा एक इन्सिडेंट झाला की स्मॉदरिंग झालं. म्हणजे तिला इतकी झोप आली आईला की ती झोपेत पाचता पाचता ते बाळावर कधी उलटी झाली तेच लक्षात नाही. अँड दॅट बेबी डाईड ड्यू टू स्मॉदरिंग. So I generally don't advise the mothers. I ask them to sit down, take a comfortable position, and then only feed them.
नाही, डॉक्टर शीतल, सेम इन्सिडेंट आपल्या काळे मॅडम कडे पण झाला होता एकदा मदर. पण इथे कसं आहे, इथे आपला रोल आहे मॉनिटरिंगचा ठीक आहे, आणि काउन्सिलिंग टू द रिलेटिव्ह, इट इज व्हेरी इम्पॉर्टंट. पण तुम्ही जर त्यांना, आणि बाकी मॅक्झिमम मदरचं इम्प्रेशन हे असते, जेव्हा आम्ही पिडियाट्रिशियन किंवा मी ऍज अ ब्रेस्टफीडिंग कन्सल्टंट म्हणून जेव्हा मी काम करते, तेव्हा मॅक्झिमम मला पोझिशन पहिल्यांदा चेंज करावं लागते. आणि जेव्हा मी पोझिशन चेंज करते, इन दॅट सिच्युएशन ओनली द मदर इज एबल टू फीड. ती डेफिनेटली हिस्ट्री देते जिच्यामध्ये लॅक्टेशनल फेल्युअर असते. तर इनिशियल 2 to 3 days मध्ये मदर इज नॉट व्हेरी मच रेडी ऑर इन अ पोझिशन. त्याच्यामध्ये रिलेटिव्हचा खूप मोठा रोल आहे, आणि इथे आपला काउन्सिलिंगचा रोल आहे. डॉक्टर शीतल, आपण जेवढं काउन्सिलिंग आपलं स्ट्रॉंग राहील, की आता ह्या आमच्या त्या इंड्यूस लॅक्टेशनच्या मदरमध्ये वी हॅव गिव्हन ओनली डोमपेरिडॉन, नथिंग मॅडम. म्हणजे मॅडमला सांगू इच्छिते मी, नो हार्मोन्स, नथिंग. वी हॅव गिव्हन जस्ट डोमपेरिडॉन. पण काउन्सिलिंगचे सेशन कंटिन्यू आम्ही 2-3 सेशन घेतले, तिला कॉन्फिडन्स मध्ये घेतले. आणि तुम्हाला सांगते, प्रोलॅक्टिनमुळे तिच्या चेहऱ्यावर इतका ग्लो आला की लिटरली तिचा आम्ही आधीचा फोटो नंतरचा फोटो कम्पेअर केला तर इनिशियली अँक्शियस अँड ऑल दॅट. तर म्हणून इथे आपला काउन्सिलिंगचा रोल खूप मोठा रोल आहे. तर शीतल जसं म्हणते, तर तसं काय होतं की मॅक्झिमम मदर्सला हेच सांगितलं गेलेलं असते. आणि कसं तुमचा रॅपो आमच्यापेक्षा खूप जास्त असतो, कारण की तुमचं ड्युरेशन खूप जास्त असतो. तर त्यांना वाटतं हे लोक काय आता आले आणि सांगून राहिले, आमच्या मॅडमनी आम्हाला सांगितलेलं आहे. तर ते हो 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 म्हणतात आम्हाला. पण माझ्या ज्या लॅक्टेशनल फेल्युअरच्या माझ्याकडे केसेस ज्या आलेल्या आहेत, मॅक्झिमम त्यांचं पोझिशन हे मी आय हॅव नोटीस इन माय, म्हणजे मी लिटरेचर नाही, आय डोंट नो द लिटरेचर, बट माझ्या एक्सपिरियन्सने मी सांगू इच्छिते की त्यांचं मॅक्झिमम पोझिशनमुळे त्यांना फेल्युअर झाल्याचे पुष्कळसे चान्सेस असतात, कारण मदर बॅकेटने टिकूच शकत नाही. तर मला असं वाटतं की यू हॅव टू वे अल्टिमेटली, बट काउन्सिलिंग इज डेफिनेटली विल हेल्प इन दिस सिच्युएशन.
एक बोलू?
हा सर.
येस सर. मुंबईला असताना आमचे सर सांगायचे की एक फॉर पोझिशन बोथ मदर अँड द बेबी शुड बी कम्फर्टेबल. की मदर शीर्षासनमध्ये तुझं दूध पाजू शकते. खूप मोठा रोल आहे.
बरोबर. थँक्यू सर.
पाटील सर, काही थोडंसं आपले एक्सपर्ट कमेंट्स.
Sandeep, thank you. Particularly in this context, I would like to suggest it is our job rather than counseling, sitting in front of the mother cot. She is in sleeping position feeding the baby and showing them how easily baby is latching and how both of them are comfortable. So I do agree with madam that the baby got smothered. But if we compare the incidence of seeds and incidence of this smothering will be nowhere compared to it. We probably may send very wrong message that a mother should not feed the baby in sleeping position or recumbent position. The comfortable position for both baby and mother and rooming in will go long way in successful breastfeeding. And every due care has to be taken, mother has to be advised. But these smothering incidences are, otherwise they would have come to journals and they would have surfaced. But if the audience is there, they should not take this wrong message that every mother has to be told that she should sit up and then feed the baby, because it becomes very difficult. She cannot sit for that long. So this is very important, and overall discussion, whatever has happened for nearly for 4 hours, wonderful discussion, very nice initiative. I congratulate you all, Agarwal sir, Naresh, Rajput, Ruturaj, and yourself, and all the IIP, Amravati IIP. Wonderful, healthy discussion and lot to learn today. Thank you, Sandeep.
Thank you. Thank you, sir. Thank you very much.
Well, we do appreciate Ramakant Patil, sir. He is there till last days lasted so long. Otherwise, he could have left in between. And seeing his so busy schedule, first of all, he give consent. Okay, I will be there. At the last note, I said, sir, you have to speak over there. He consent, yes, I'll be there. And till now, he's with us, sir. Thanks from all of us.
Thank you.
That's what I meant.
हाँ सर.
आणखी काही बोलायचं आहे?
नाही, it's okay sir.
ऋतुराज.
Yes, sir. Thank you, sir. After this excellent panel discussion, this brings us all to the end of our last session, and also this virtual gathering, which turned out to be a truly academic feast. For this, I would personally want to thank to all organizing, Satish Agrawal sir, Pandrikar sir, Naresh Thade sir, and Raju sir for taking effort in organizing such a nice, wonderful CME. Lastly, I would like to invite Dr. Sushil Rajput sir to give a vote of thanks. Sir.
What a fabulous Sunday. We got a brunch plate with blend of knowledge and experience from all different faculties mastered in their branch. I, Dr. Sushil Rajput, on behalf of IIP Amravati, wholeheartedly thanks to our chief guest, Dr. Jayant Pandrikar sir, who took off their time from their busy schedule and chaired the session. We also thank to our chairpersons, Dr. Vinayak Patil sir, Vice President Maha IIP, Dr. Nistani sir, Dr. Manisha Kasture ma'am, Dr. Milind Bardia sir, Dr. Raghuvanshi sir, Dr. Pratibha Kade ma'am for their active role in the CME. We also thank to our super senior backbone and convener of the CME who devotedly and single-handedly shaped the CME successfully, that is Dr. Satish Agrawal sir. We thanks to all speakers, Dr. Manjusha Taide ma'am, Shripat Dagiza sir, EB member CIP, Dr. Ramakant Patil sir, Dr. Gajbi madam, Dr. Ninath Chaudhary, Dr. Rushikesh Gato, Dr. Khandewala sir, who brushed up our knowledge and shared some new interesting facts which we were unaware of it. We also thank to Dr. Moderator Dr. Sandeep Dankade sir and panelists Dr. Sumita ma'am, Jagruti Murke ma'am and Dr. Sheetal Potode ma'am for the excellent panel discussion. And the last, we thank to our treasurer and session in charge, Dr. Ruturaj Deshmukh, who smoothly conducted the session. And finally, thanks to all the lovely audiences who patiently attended the CME and encouraged us to conduct such type of CME in future. And with this, give us the permission to end the session. Thank you.
Sushil, 2 names are to be taken. Our MNC
Yes, sir.
Gaware sir and Dr. Vaishali ma'am. And the most important person is Mr. Prakashji, the event person who managed all these things so beautifully.
Yeah. I thank Prakash sir also.
Yeah.
And lastly, on the position of the mother, 40-degree angle is the best position for both to avoid the risk of aspiration to the baby.
So officially now CME is over. So if anybody wants to give any opinion, any comments, Please be free. Now, this is a just informal thing. Prakash, you may put on this YouTube streaming.
Yes, sir.
ते बंद करून द्यायचं.